Hello, good morning. My name is Yolanda Manuel. I am the IAPAC's Regional Director for Southern and Eastern Africa, and I work mainly with the fast-track cities. I want to welcome you all to this session. We'll be discussing viral hepatitis, and the topic of the session is tackling viral hepatitis, integrated responses across the fast-track cities network. Briefly, I would like to say that the purpose of this satellite session is to further fast-track cities' ability to develop and implement integrated HIV and hepatitis response globally by exchanging best practices and by addressing barriers to an effective and equitable urban HIV and hepatitis response. Although most of the people think that fast-track cities is only focused on HIV, I have to say that in this document that we call the Paris Declaration on Fast-Track Cities Initiative, on Fast-Track Cities, the document that the mayors and the representatives from the cities have to sign in order to join this global movement. There are 4 chapters where we are talking about fighting hepatitis. The first chapter, where the mayors have to commit to achieve the 95-95-95 targets, which will put us firmly on the path to ending HIV, TB, and also viral hepatitis by 2030. The city representatives are also committed to focus their efforts on all people who are vulnerable to TB, HIV, and also viral hepatitis. Cities are also committed to integrate health and social programs to improve the delivery of services, which include viral hepatitis, and to mobilize resources for integrated public health responses, which include viral hepatitis. Well, for this session, we will have 5 presentations. The presentations will be, 2 presentations will be here in the room, and the other 3 will be virtually, and each presenter will have only 10 minutes to deliver the presentation. After the presentation, we will have 20 minutes to the panel debate, and the moderator will be Professor Jeff Lazarus. At the end, we will invite Jessica Hicks to do the closing remarks. So with no further delays, I would like to invite Jeff Lazarus to deliver his presentation, but let me know that he is the head of the Health System and Infectious Disease Research Team at the Barcelona Institute for Global Health. He is well known for his work on the people-centered health systems and for launching micro-elimination approach in hepatitis C and elimination efforts for the COVID-19 about long-term and well-being for people living with HIV. He is the co-chair of the HIV Outcomes Europe and on the EASL Public Health and Policy Committee. He earlier worked to WHO and the Global Fund, and he is the past Director for Health System Global. Please. The floor is all yours.
Okay. Thank you very much, Chair. I'm just figuring out where best to stand, maybe over here, so I'm out of everybody's way. Well, thank you for the invitation to speak at this session. Thank you, IAPAC, for hosting the entire conference. It's so important to focus on how cities can move faster in line with earlier work at the World Health Organization on city health. And that's something we've been doing a lot in Barcelona, where I've been working the last 5 or 6 years at the Barcelona Institute for Global Health. I'm going to share some of our experiences across Spain in 10 minutes, so you can tell me, Chair, when there's 2 minutes left. We're well familiar with the continuum of care. We know it from HIV, the 3 90s, as well as the long continuum that's presented in that strategy. We also have it for viral hepatitis. We've also worked on reducing it because it's not so easy for countries to report or cities to report. We move from all infected, the prevalence, down to follow-up and chronic care, because WHO, in its wisdom, reminds us that many people present late for care and will already have underlying liver damage and need longer care than just elimination of the virus. So we also have updated targets. I won't go through them from WHO. I'll just remind everyone that it's important to be familiar with the new 2022 targets that were approved at the World Health Assembly in May of this year, and particularly draw attention to a target focused on people who inject drugs, the population most at risk and with the highest prevalence of viral hepatitis, or at least particularly hepatitis C. As mentioned, many people will present late to care. Others will say the health system is diagnosing them late. So whether you call it late diagnosis or late presentation, we have a problem. It's difficult to measure. We set out to measure this across Spain and found that almost 1 in 4 people presenting for care in a hospital were already late, i.e. having a fibrosis stage 3 or 4. One place where we can eliminate hepatitis C, following the EASO International Liver Foundation's micro-elimination approach, is in our public hospitals. It can be challenging to reach marginalized populations. We need to double down on our efforts to do so, but it's easy to reach people in hospitals, but it's sometimes challenging to do so in collaboration with our colleagues. So together with clinicians across the main hospitals, or hepatologists and infectious disease doctors in the main hospitals in Madrid, we set out to see, can we eliminate viral hepatitis there? What we found first was that nearly 1 in 10 people at risk, populations with a known elevated prevalence of hepatitis C, had not been tested for hepatitis C in spite of being in a public hospital. Madrid has made a special extra effort on hepatitis C elimination, so it's probably a best case scenario. And so while some people might say 91% had been tested, we would emphasize that almost 1 in 10 had not been. We went through all of the medical records in these hospitals for 6 key populations that you can see here. We reviewed records from over almost 4,000 patients, and I won't go through all the details in the interest of time, but again, we found that about 10% hadn't been tested, and that was particularly the case for people who inject drugs, who had been in the addiction centers associated in or with those particular hospitals. So some of the solutions to elimination in hospitals, and here we focused on a particular city elimination effort, an integrated effort where we reached out to nephrology, hemophilia, transplant departments, any department where there would be patients at an elevated risk. We then pulled out 10 required actions to eliminate hepatitis C in hospitals. Part of it could also be applied to hepatitis B, and I think it can be carried out in hospitals anywhere. We just happened to focus on Madrid. One of the key recommendations was reflex testing. Far too often around the world, when you test positive for antibody positive for hepatitis C, there's not an automatic test for RNA. A new sample is required. It needs to be sent back to the lab. The patient has to come in and out, and often they'll have 4 or 5 visits before they're finally confirmed and initiating their treatment. We need to simplify processes. We need to use rapid diagnostics. We need to provide culturally sensitive and accessible information, use peer navigators through the care pathway. So that's getting outside of the hospital, a project we're also running, led by Jorge Valencia and Pablo Ryan in Madrid, going out in a mobile unit to reach populations that won't even make it to those public hospitals in the first place. So that's a decentralized effort to try and eliminate hepatitis C in the community and in the public hospitals. The hospitals, as I mentioned, we thought would be a lot easier. They're also proving challenging. So we know, going back in time a little bit, in 2013, 2014, with the advent of DAAs, that we were going to need to change our models of care. This was no longer just a liver issue in hospitals. We need to be thinking about elimination in city and country, prisons, harm reduction centers, community health centers, anywhere else where there'll be large groupings of people. And when we reviewed the literature, we were really able to sum up that such models of care needed to be simple, targeted, multidisciplinary, scalable, and above all, patient-centered and affordable. We need to listen to our clients and understand what works for them in order to be able to provide the services they need. In the greater Barcelona area, migrants from sub-Saharan Africa are not accessing care. They approached us and said, we need care for hepatitis B. Are you able to help? We secured funding, and we go out every week into the community, into the mosques, into the religious centers, which are sometimes under highways and abandoned buildings, together with representatives of the community. We do a rapid test, and then we do a dried blood spot test using Roche's plasma separation card, which we take back to a lab at our convenience, because you can keep them for 40 days or so at even up to 40 degrees, which works for Barcelona. And then if they're negative, we go back into the community, we vaccinate them with a vaccine from the Barcelona Health Services. If they're positive, together with peers, we help get them to Vall-d'Hebron Hospital Clinic, the two main university hospitals in Barcelona. All of that until they get into the hospitals, done without a doctor, with peers and staff from our team who go into the community. In hepatitis C, that's a B project. In hepatitis C, we're working on elimination on the 3 Balearic Islands. Probably everyone's familiar with them, Mallorca, Menorca, and Ibiza. But there are a lot of people who inject drugs there. There are migrant populations as well. And there are 15 addiction centers called UCAs. So together with the UCAs, for the first time, they're testing for hepatitis C. So believe it or not, you have an addiction center. People go there often because they have an injecting drug problem. They want help, but they never get a hepatitis C test. So we've instigated that there, and through telemedicine, they never need to go to the hospital to be able to get tested or treated for their hepatitis C. So we've launched new pathways there, both at the addiction centers, in the prison, and the Metabus, a bus that goes around providing methadone every day for around 100 or 110 people in the city of Mallorca. We've now been awarded funds from the European Commission to take this across Europe. So we'll take it from Barcelona up here on the right of Spain to Madrid in the center, working specifically with migrants. And we'll also take it to Italy and to Greece, working with community groups, hospital groups, in order to address hepatitis B and C in Athens, in Rome, in Madrid, and continued in Barcelona. I'll start to come to an end. I'll just remind people that Spain, like many other countries, has suffered greatly during the COVID-19 pandemic. And at the beginning of the pandemic, we showed that there was a big drop-off in use of harm reduction services, a drop-off in viral hepatitis diagnoses, and a subsequent drop-off, obviously, in treatment initiation. And although we don't know it, I would assume probably a likely increased spread as fewer people were getting diagnosed and treated. So we need to kind of double down on our efforts. And some of the things we can do are to have integrated approaches. We talk about integrating B and C, and even HIV. We also need to integrate now with COVID-19 efforts. So what we did was, in marginalized populations who were not getting vaccinated for COVID-19, in spite of the authorities telling us that everyone in their country, or sorry, in their cities had been vaccinated. And it's true that Spain reached a 92% or so vaccination rate, and Madrid in particular did very well. So did Barcelona. Still 8% not vaccinated, largely in the marginalized communities. So using the networks we had established for viral hepatitis and HIV, we went into those communities like Cañada Real, the largest shanty town in all of Europe. We reached homeless people there, many migrants, many people with substance use disorders, sex workers, refugees, including undocumented migrants. And we did a pilot test to show that integrated care can work. We tested the acceptability of when you're vaccinated for COVID-19, in those 15 or 20 minutes, what do most of you do after you've been vaccinated? Well, we tend to look at our telephones, sit around, we're kind of isolated on that chair in a center waiting. We said, how about if we do a rapid test for hepatitis C? Everyone agreed. 9% RNA in the Madrid population. That's just remarkable. 0% in Barcelona, because in Barcelona we tested at an addiction center which already had hepatitis C testing, so there it was really to test the acceptability, so this could be done in other centers. In Madrid we went into the community. If they weren't vaccinated for COVID-19, they very often had hepatitis C, and 6 cases of HIV found as well. So We need to integrate services. That's why we're having this session. We need to integrate B and C and HIV, and now together with COVID-19. There's been recommendations from Spanish stakeholders to do this. Similar pilot studies were carried out in Italy and Canada. Some found lower, some found very low numbers of positive. That means you're testing in the wrong population, but we need to show that we need to combine our efforts because there's a lot of political will to address COVID-19, or at least there was. There's not much political will to address viral hepatitis in general, so we need to join up our efforts to do that. So thanks to my team and everyone who's been contributing to this work, those who are going into the field every single weekend, meeting in the mosques, meeting in the religious centers, meeting in the shanty towns, because it's a thankless job, but actually I would say that the populations receiving them are so grateful, particularly during the pandemic where they've been isolated, that people are coming there and providing care together with their peers. Thank you.
Thank you, Jeffrey, for your presentation. We will now move to Australia, Melbourne, and I would like to invite Mark Stove to join the session. Mark is an infectious disease and behavioral epidemiologist and head of the public health at the Brunei Institute and professor of public health at Monash University. He has studied epidemiology and prevention of blood-borne viruses and sexually transmitted infections for over 20 years. He specializes in development and maintenance of disease surveillance and biobehavioral cohort studies and the development, evaluation, and refinement of disease prevention program, including community-based randomized controlled trials. Mark, I would like to ask you to share your screen, and the floor is all yours.
Okay, thank you very much. I'd like to thank the organisers for inviting me to talk today. I'm just going to go to presenter mode. Can people see those slides okay?
Not yet, not yet.
Not yet? Just let me know when.
Okay.
Are they there? Yep.
No, not yet. We are still waiting.
No. Okay, sorry about that.
It's all right.
It's a long way for the internet to travel. Can you see any? Are you still seeing my image or?
Your image.
Right, I've got my, just go back and make sure I'm sharing correctly. Apologies. People able to see them now?
Okay, now we can see the presentation. Oops.
Okay, great. Thank you very much.
What is it?
Yeah, I'll provide an
okay.
overview. Sorry, have we got them? No.
We just lost the presentation. Now it's on. Now it's on.
Okay, back. Let's hope they stay there. Thank you very much. I'm going to provide a very quick overview of Australia's response in relation to hepatitis C elimination, where we're at now and where we're going, and try and make that as applicable as possible to local level responses to hepatitis C in light of the Fast Track Cities approach. I'd like to first acknowledge the traditional owners of the land on which I'm sitting at the moment, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present and emerging. A quick overview of today's talk. I'll provide a very quick overview of Australia's implementation environment, our progress to elimination thus far, and on the basis of that progress, the priorities for achieving elimination by 2030. And that last part will be elements that will be most applicable, I think, to fast-track cities and local responses to Hep C elimination. First, the implementation environment is best characterised as a high-quality combination approach in Australia that's underpinned by harm reduction and universal health care. Firstly, in relation to harm reduction, it's been a long-standing foundation of Australia's response to drug use. Very early implementation of needle and syringe programs that has led to Australia having one of the lowest HIV prevalences amongst people who inject drugs globally. We have widespread access to opioid agonist therapies, and we've maintained that coverage of both over an extended period of time. So Australia is one of only 4 countries at the moment that is listed as having high coverage of both NSP and OAT. In addition, we have a universal healthcare system, our Medicare system, and DAAs were listed on this as a subsidised medicine in this system in March 2016, which not only allowed free and low-cost access to treatment, but it also was listed in a way that allowed prescribing to happen in primary care through general practitioners and nurse practitioners. It was available to all people living with hepatitis C, regardless of disease stage or risk behaviours, with no limitation on retreatment of reinfections. Importantly, DAAs were also subsidised into the prison health services that are run by jurisdictional departments of justice, and this was a special listing to allow that to happen. So we've got this nirvana situation, right? We've got high coverage of primary prevention, and we've got the basis for a treatment as prevention approach in Australia. So how are we going in relation to progress to elimination? I'll share these slides to anybody who would like them, but if you'd like to see a detailed report on our progress to elimination, please check out the Burnet Institute website, this progress to elimination report that we prepared with the Kirby Institute, noting that a new report will be released in November 2022. Firstly, in relation to treatment coverage, since 2016, we've treated nearly 90,000 people with DAA treatments, which represents approximately half of people living with chronic hepatitis C at the end of 2015. Importantly, prisons have remained a really important part of this rollout. In 2020, over a third of all treatments that occurred in Australia occurred in prison treatment programs. And in 2021, that's actually increased to 40% of all treatments in Australia occurring through prisons. However, as we've seen in many other countries, once we move through people living with chronic hepatitis C who were warehoused and waiting for DAAs to arrive, we've seen quite a dramatic decline in treatment numbers over time. Pleasingly, we've seen fewer treatments proportionally provided by specialists, but we haven't seen the uptake in general practices or amongst nurse practitioners that we would like to have seen to replace that. In relation to incidence estimates, so we're yet to see a population impact in relation to treatment as prevention. So this is data from young people who have been notified with hepatitis C as a quasi indicator of incidence, thinking that these people will have initiated injecting relatively recently. We've seen no change in young people's notifications, and even in relation to direct incidence estimates. So this is amongst repeat testers at high caseload clinics for people who inject drugs. We've seen very little decline in incidence or movement in incidence since 2016. We have seen declines in incidence amongst people living with HIV, so co-infected with HIV and hepatitis C. We've been very successful in integrating hepatitis C care into HIV care. And we scaled DAA therapy up integrated into ART. Around the same time, we also scaled up PrEP. So we actually haven't seen what's been seen in some countries in relation to an increase in hepatitis C incidence amongst HIV negative men using PrEP. And we think that's largely because of the successes in integrating DAAs into ART therapy. So how are we going in relation to these treatment numbers in our progress to elimination? So this was modelling done by the Kirby Institute, where they looked at optimistic, intermediate and pessimistic estimates of our rollout of DAAs, noting that it's only the pessimistic number of treatments annually that was modelled to have us missing our elimination targets. So in those first 2016 to 2018, you can see our annual numbers were well above the optimistic rollout estimate. In 2019, they declined to about what we would want for an optimistic rollout of DAAs. By 2020, we were hitting the intermediate rollout level. And by 2021, we'd fallen below the pessimistic rollout of DAAs. and that would project us to have us missing our elimination targets by 2030. The 2020 and 2021 estimates have been affected by COVID, as in many other parts of the world, but still this is a very worrying trend. And I think also we need to consider, as prevalence declines in the community and people, more people are treated, it will become more and more difficult to case find people because there's fewer people out there living with hepatitis C, and it will become more challenging to maintain these levels of treatment. And that's what we looked at in this modelling published in the Medical Journal of Australia. The Kirby modelling did not take account of testing rates in their model. In our model, we looked at testing rates and looked at their impact on elimination. And on this side of the chart, you can see that decline in treatments over time. And on this side, we have our testing rates. And while we saw testing increase around the implementation of DAAs, we've seen testing rates decline over recent years to levels only marginally above what they were before DAAs were rolled out. And effectively, our model says we're going to run out of people to treat because we're not testing enough and we're not trying to find enough in the community. So what about, given that's our situation, what are our priorities for achieving elimination? We published this article last year where we adapted a diffusion of innovation theory, and innovation here being, the innovation of DAAs, and essentially concluded that we can't do more of the same. We can't use the same strategies we used to get treatment out to people in the first phase of elimination. And what's essentially required is we need to adapt structural systems that recognise the competing health and social priorities of the affected population. One of the places we need to do better is the integration of hepatitis C testing and treatment in opioid agonist therapy programs. And this is data from our high caseload clinic network that showed only 17% of people who initiated OAT between 2012 and 2019 had a hepatitis C test within 12 months of their initiation. Only 4% of these people had an antibody negative result in the 12 months prior to initiation, and 56% of those tested were antibody positive. So this is a group that where largely their hepatitis C status was unknown, and of those that were tested, we got a very high prevalence of hepatitis C. So we need to integrate hepatitis C testing better into these types of programs. Also, this is data from a pilot project done by colleagues at St Vincent's Hospital in Melbourne, which was a point of care testing rollout at the Melbourne supervised injecting room. And I've highlighted the data there around, of the 64 people who were found to be RNA positive by rapid testing, an incredible 94% were informed of their results, and 93% of those who were informed commenced DAA therapy. And this is largely driven by repeat attendances at the supervised injecting room. So these are high-risk people who repeat attend to a service, a really high priority group. We also need to think about adapting our models of care. So this is Quick Start, a 4-arm point of care clustered randomised controlled trial that we're midway through across Australia, where we're testing 3 point of care testing arms against standard of care to look at the rate at which people commence treatment. The arm that we're probably most interested in is this same-day treatment arm, which is based on a 5-minute read of an antibody test only, which is highly predictive of people who progress to, who are chronically infected based on Jordan Feld's work. So we're very interested in this very rapid same-day treatment, send people off in a short period of time with DAAs and how that type of a system can increase coverage. We're also very interested in using surveillance systems to follow up people who've been lost to care, both people who are prospectively notified within these surveillance systems, but also retrospectively, so look back to people. And this is a program that we're initiating next year across all Australian jurisdictions, working with public health units in government, community and clinicians to design better systems to follow up people who are diagnosed. We're also, the Commonwealth Government has commissioned us to adapt the HIV Optima model to try and think about how we can best allocate investments to meet our elimination targets. And finally, I'd just like to show this data here Australia invested very heavily in DAAs in the early period, and our research suggests that this has been highly cost effective over time. So really started paying back in 2022, and by 2030 we estimate we'll have had an economic benefit to Australia of nearly $6 billion, and that's based on current estimates of coverage and cure, and we think that achieving elimination could increase this economic benefit even more. So thank you very much. There's my email address for people who'd like to see. I'm happy to send these slides or if you'd like further information. Thank you very much.
Thank you, Mark.
I shall attempt to stop sharing. Just bear with me.
Thank you. We will now move to London, and I would like to invite Ian Jackson to deliver his presentation. Ian is the London Specialised Commissioning Lead for contracting and commissioning of £5 billion worth of NHS funding. He is also the Programme Director for the HIV and Hepatitis Opt-out Testing Programme, which is being implemented in all London's 28 emergency departments. Trustee of the Rethink Mental Illness. Please, Ian.
Thank you very much. Yes, thank you. Hello, everyone. So I'm not an academic, and I'm not a medic. I'm a payer, I guess, is the best way to describe me. And I need to do some background, which will involve HIV, but will loop straight back into hepatitis. So don't worry if you're particularly here for hepatitis, because I need to explain the background and also how we can utilise fast-track cities as a concept and all the great work we get out of HIV, and how you can use some of that information into to inform what you're doing around other groups of people that you might want to get on treatment. And we have in England a Hepatitis C Elimination programme, which is very ambitious, and we want to eliminate hepatitis C by 2025. That does come with a very large budget, and although I do work with a very large budget, clearly I don't have much discretion about any of that budget, and although I've got £5 billion in the spend that I work with my colleagues on, the reality is the requests against that is about 5.3 billion, so actually it's just about trying to control it within the spend already. But what it does mean is that we have, when relatively marginal pots of money do appear, they are very large pots of money, and they, in this case, are being used to try and eliminate hepatitis C. And in England we have basic preconditions for elimination, which are that the NHS will pay for the drugs, so the health system will pay for drugs irrespective of where you come from, irrespective of your right to be in the UK or migrant status, because that's the only way you can get to elimination. It's obvious to everyone here, I know. So, the Independent HIV Commission, which was supported by three very major charities, the Terence Higgins Trust, the National AIDS Trust and the Elton John AIDS Foundation, developed recommendations to end new cases of HIV by 2030. And within the specific action plan, which was published in December 21, £20 million was found because the charities lobbied our ministers, and our ministers were able to find £20 million, or effectively ordered NHS England to find £20 million to work on elimination in our major areas of HIV prevalence, and that was London, Manchester, Brighton and Blackpool. And there are significant challenges for trusts in implementing opt-out testing, but opt-out testing was always what the HIV clinicians wanted. It was the single thing that everyone kept saying to me about how do we get to zero. We do opt-out testing in emergency departments. London has 9 million people, 28 emergency departments, and about 2 million visits to emergency departments from individual people. So there's repeat visits as well, but about 2 million people go to an emergency department in London a year. So we thought with this, well, if we've got some money to do opt-out testing for HIV, it seems to be sensible to reverse engineer the question to say, well, what's the most we could do with that test? If we're taking blood and we're taking a sample anyway, could we test it for other things? And the answer came back, yes. In the way that we test in England, you can test for hepatitis B, hepatitis C and syphilis. Now, the NHS, the organisation I work for, isn't the responsible payer for syphilis, so we weren't able, or haven't yet been able to do syphilis. But I then had a conversation with my hepatitis C colleagues who are working on this elimination programme, and they provided additional funding on top of the 20 million. So for London's share per year of the money is 5.3 million for HIV, and the National Hepatitis Programme put another 3.8 million pounds, this is sterling, which is worth a lot less than it used to be to everyone else in the room, but never mind. And we coordinated with our 5 systems in London. We have new integrated care systems. There are 5 of them. And we found people who wanted to work on the principle of getting all three viruses eliminated if we possibly could, or under control, certainly. And that was quite ambitious because we wanted to do it absolutely everywhere. We didn't really offer an alternative to people who didn't want to do it, and we had to solve all the various pathology and technical problems that we'd had to make that work. And also, we had a kind of feeling that it was time limited, because although people say yes to things in healthcare in England, they quite quickly come back and say, actually, we need to save some money on this. So we had to do a rapid rollout across all 28 different services very quickly. So from December to April, we got going in most sites. And what we were told quite clearly was you are going to find more hepatitis B than you find anything else. If you do this triple testing, you will find more hepatitis B in London than you will find hepatitis C or HIV, given where we are relatively against our progression against getting to 0. And actually, the amount of hepatitis B you find will overwhelm your doctors. It will overwhelm the amount of people and resource we have to be able to treat that within a current very, very stressed system. The system is still stressed from COVID. So how do we do something about that? And our response was to say, well, what we can't do is just do more of what you're doing. That's an unreasonable ask. That's what all health systems get asked from time to time, is can you just do a bit more? I don't think that's the right approach. So we coined this term of dynamic commissioning. And dynamic commissioning, I'm a commissioning director, so commissioning is what I do. Dynamic commissioning sounds more impressive than it technically is, because what it really is can we make something up as we go along like we did in COVID? Because in COVID, we changed what we did every single day, and everyone had that mentality that we could change what we did. And everyone did it. And I don't really want to lose that. I think that was such a powerful driver for being able to react really well in a health system, that actually if we can harness some of that COVID energy in a good way, and go, well, actually, you need to work out how you're going to deliver equitable access to support, how we're going to get our testing rates up really high, and how we're going to implement effective care within our current capabilities. And I don't mind how you do that. You might need, a consultant as overseeing a batch of patients, because we're suddenly going to send several, hundreds or thousands more people into your caseload. But don't be stuck in what you used to do. You don't have to do things because your individual hospital tells you to do it this way. We'll do it as a collective. We can make these 5 systems, which are brand new since July 2022, we can make them really mean something. We can give them a program to work on, which will help them establish their own identity. And the other thing that was really important about this whole program across the three viruses, so Hep B, Hep C, and HIV, was that we co-design everything we did with the community. So we don't really move. Fast Track Cities London doesn't do anything without its community. It just doesn't. It wouldn't even occur to us that we would have conversations without people in the room from the community. A lot of them are here today. And we were having conversations as we were working out the opt-out program with the community, and they were sort of asking me, well, could we have this, or it would be great to have that. And I thought, well, the things you're asking me are more important than whether I can say yes or no, because these are your reasonable demands, and it feels strange that I would say that. It's probably not that normal, but I really wanted the community to be part of it, and we've written this first 100 days report, which has gone into a sort of publishing black hole, which we're hoping to publish very soon, about the first 100 days of the programme. But within it, there is this charter, and because what I said was that what you want is more important than the individual officers working on the programme. What the community wants will always be the most important thing. So what I want to do is codify what you want across all of these things, and you can hold us to account for that. So whether it's me, whether it's someone else, the community gets to choose what it wants to do. It can change its mind about these things, but they seem completely reasonable. We made money available to the community to do follow-up, so the Hepatitis C Trust in particular is very involved. So anyone who is picked up with hepatitis C will have a follow-up with a peer support from Hepatitis C Trust. We have the same for HIV. Hepatitis B is a really emerging field for us. We weren't routinely treating, and this has actually given us a good problem. And it would be immoral. Now we know that we can do that test and it isn't costing us extra money, it's immoral not to do it. We have to find people if they're sick. And we do this all on an opt-out basis, so that means there's a poster that says we're going to do this test unless you specifically say you don't want one and you're over 16. And that's to all of those people. So that's to anyone who's already having a blood test. So we don't do it if you're not having a blood test, but that's a target for London of trying to do about 800,000 tests a year additionally to what we were doing before. And that's 800,000 HIV tests, 800,000 Hep B and 800,000 Hep C each year. And these are the results for the first 4 months of this program. And so for context, I'm going to jump to the numbers here, which is at stage 4, because you can have these slides later, it's fine. But we found 129 new HIV diagnoses, and London, we think, has about 1,700 people living with HIV who we haven't found yet, so who are not known to care. We found 166 new hepatitis C diagnoses and 380 new hepatitis B diagnoses, and actually hepatitis has only started in the north bit of London. So South London is coming on this month. So this is a really small, it's a huge number of new cases to be found, and we're not fully live yet. And this is the amount of tests that we've done to get there across the different pathology. So 249,000 HIV tests, 90,000 HPV antigens, 78,000 HCVs, and 8,000 HCV RNAs. And that's 28 out of 28 sites are now live doing opt-out HIV testing. So there's only really 2 targets for this program. One is get started and do some testing, and then you're doing it. And the second one is, can you get up to 95% of people who are already having a blood test willing, because that's kind of our maximum. That gets us to the 800,000 to 1 million tests a year that we're looking for. And I really thought, so our emergency departments are possibly under the most pressure they've ever been under in London. And I was really worried talking to our emergency departments that they wouldn't want to do this. And what was fascinating from my point of view is that they really did want to do it. And the reason they cited was because they get feedback. So a lot of our emergency clinicians only know the status of a patient when they leave their department, and they never hear about them again. So the chance to do something that will put people into long-term care for this many people, we are going to get to thousands of people this year doing this, and those are people who never knew they were sick. You know, this is any reason testing. It's not targeted testing. It's absolutely anyone having a blood test. So people are being found with Hep B, Hep C, and HIV who didn't know they were sick, and that is, I think, the way to get to elimination for a city as urban as London, as visited as London, because actually people will get sick eventually and will all roll up into emergency departments. It's easier to manage than primary care because although it's a lot, it's 28 departments, not several thousand primary care sites, and everyone wants to do it. There is a real goodwill around doing this work. So what next? Implementing the triple test in all of the sites. The triple test also, by the way, destigmatizes HIV testing. Because if you go and say, I'm going to test you for HIV, we get all the relative stigma for that. The more tests you can put in that test, the less stigmatizing it is. We're just trying to find what's wrong with you. You're in an emergency department, you're sick. Increasing the uptake to 95% is the next aim. I don't know how realistic that is. Some sites, Ian Cormack's here from Croydon, has got up to 98% in some of the months he's been running that program. He's a very committed individual clinician running a relatively small program in terms of the hospital he worked in. Blocking just means that if you've already come in, we won't test you again for 6 months, so it's just identifying, so we're not wasting tests, but there's no wastage in terms of repeatedly testing the same person if they are repeatedly attending emergency departments. Ensuring the culturally appropriate support, so that's about the Hepatitis C Trust, it's about the HIV charities all working together and making sure that we've got a peer as part of your support network rather than just a very medicalised approach, because we know that the community is actually the key to getting to zero. Introducing an online form and data reporting, which is very much not my bag, but Steve Hindle, who's sitting here with me, is totally in control of that, so I'm very pleased about that. And also, as part of the 3-year programme, we've agreed with the UK Health Security Agency, who hold all the confidential patient data, that they will run a research project with the University of Bristol to evaluate properly the programme as we go, but we're going to do it every year for 3 years, so it's a rolling programme of research with interim results. So almost like dynamic commissioning of the evaluation at the same time. And then just to continue the dissemination of learning, because this is those sorts of numbers, finding those sorts of numbers that fast, that was 4 months worth of data, is exceeding everyone's expectations about how well we thought we could do, and everyone has done it. So that's it. Thank you.
Thank you, Ian, for your presentation. From South Africa, I would like to invite Kalavanya Padayeshi to deliver her presentation. Kalavanya has a clinical psychology background with over 8 years of experience in working with vulnerable populations in the health and psychosocial environment, with experience in working with children, sexual abuse, victims of crime, psychosocial support, public health, hepatitis, HIV prevention program for key populations, public health, and harm reduction. Currently, is working at NACOSA, has a people who use drugs program specialist. Kalavanya, please, the floor is yours.
Thank you very much.
We can project your presentation.
Sure.
Okay.
Just let me know if you could see.
Yes, yes.
Okay. Good day, everyone. Thank you for allowing me the platform to share the work that we do around key populations in South Africa, particularly in eThekwini. Just to give you some background, I started one of the first harm reduction programs back in 2014 in South Africa, eThekwini, for people who inject drugs, people who use drugs. And I just want to share with you the work that we carried out in terms of viral hepatitis for key populations, particularly focusing with intravenous drug users. Okay, so I just want to give you a background around the NACOSA, outline for today around the NACOSA PWUD program, a background into the HBV and HCV prevalence amongst drug users, how we integrated viral hepatitis service within existing harm reduction services, and some of the challenges and successes around program implementation, because this is a fairly new program that we've implemented within a harm reduction scope in South Africa. So just a breakdown around, service of package. We have core services and layered services, and your core services are your harm reduction services for injecting drug users. We offer a comprehensive biomedical package of service, that is your HIV testing and counseling, TB screening, STI, initiation on for ARVs, as well as determining risk, the level of risk for intravenous drug users, distribution of condoms for drug users and their sexual partners. We offer a host of harm reduction counseling through peer education and navigation. We are a peer-led outreach program. We thrive on a peer-led model to run our program. We are focusing now, particularly in this Global Fund grant, around injecting females and strengthening the advocacy work around drug use, sensitization, as well as viral hepatitis. We also we have sites in South Africa under the Global Fund grant who are currently offering opioid substitution therapy, OST treatment, in which we integrated our hepatitis screening and treatment for. Okay, just to give you a background into the viral hepatitis in South Africa. So viral hepatitis in SA is a significant problem, with SA being one of the highest HBV prevalence globally, specifically amongst key population, that is your sex workers, your men who have sex with men, your people who inject drugs, with the 60% of the population being hepatitis B and HIV co-infections, particularly in public health clinics, but there's no treatment provided. We are seen within the harm reduction program, working with people who inject drugs, that there's a high prevalence of HCV positive amongst the intravenous drug users population. So just demonstrating around this, back in 2017 and 2018, there was a pilot study that was done in 3 main cities in South Africa, which is Durban, eThekwini, City of Cape Town, and Pretoria, through the BMSF study within the current harm reduction program, which was run through TB HIV Care at the time. This was not a NACOSA grant, NACOSA funded program at the time, but it was still through Global Fund. Ideally, just the program was run to map out size estimation around the number of Hep BV and Hep CV positives within the PWD population, and to increase advocacy at a local government level, national government level, provincial government level around hepatitis treatment and high-risk populations. So you would see with a total of 941 PWID clients that were screened for hepatitis B and hepatitis C, including HIV. 5% of them was hepatitis B positive, while 45% was hepatitis C positive, with a 21% HIV co-infection across the 3 main cities. While narrowing down and focusing on eThekwini as a fast-track city initiative, we see that there was a total number of 318 clients that were screened, with the 4% being hepatitis B positive and a 29% being hepatitis C positive, with the 17% co-infection with HIV. Remember, this was the first mapping study that was carried out amongst people who inject drugs, key population in South Africa, and you can see a quite high rate in terms of hepatitis C and HIV co-infection. And no services, current services within the local government, national government, or within the harm reduction program was carried out back in 2017 to 2018. This was just a pilot study. So fast tracking back to 2021, 2022, through the Global Fund and NACOSA funded PWD program, literally the approach was an integration of services into the current opioid substitution therapy services, into the methadone program, with the existing harm reduction program. So due to the limitation and accessibility of screenings and the treatment for hepatitis in South Africa, the Global Fund and NACOSA decided, as I mentioned, to integrate hepatitis programs within existing harm reduction programs under the current OST program. There was limited funding for this, for screening and treatment, and only a small cohort could be reached to ensure sustainability and adherence within HCV treatment for clients while being stable on OST. So you would see, we would recruit clients to be part of our OST program, and once clients are stabilized, they would have their full biomedical screening, which was inclusive of screening for hepatitis B and hepatitis C. If you were negative for hepatitis B, you would have received a vaccine, first dose and second dose. If you screened positive in the rapid test, we would do your blood workup, your PCR, ALT, and your platelets. Should the blood work receive positive, we will initiate the client on DAAs. It's a 12-week treatment. We have, panel discussions, echo calls, to discuss progress of patients, difficult patients in terms of completing SF12 bloods and results come back non-detected. Okay, so in the current scope of work, so the program in eThekwini started opioid substitution therapy in January of 2021 through the existing Global Fund program. We received confirmation and funding to begin the viral hepatitis program in August of 2021. This is the current data. This is focusing only on eThekwini, as I mentioned. So a total of hepatitis C positives was 86. 73 were male and 13 were female. Out of that, 22 of the 86 have completed treatment and 10 clients are currently on treatment. So you would see we had 123 clients screened for hepatitis B, hepatitis C, HIV. We have a 28% HIV prevalence and a 63% hepatitis C prevalence, 2% hepatitis B prevalence. 22 clients have completed treatment and are cured from hepatitis C, and at least 122 of the clients within the program has received the first dose of the vaccine. You would see also focusing on the disintegration of male and female. We have a high number of male clients and only 15% of female clients. We are trying to strengthen services targeted for females due to the vulnerability and stigmatization that females within the settings experience. So we trying to increase services and draw females into our program, which is obviously including the screening of hepatitis, but inclusive of PrEP as well. So we would, there was a good number of clients that became lost to follow during this period. There was one female who, one of our female clients who was pregnant, hepatitis C positive, currently on OST taking methadone. She completed a treatment and she's doing extremely well as well. Okay, so in terms of our successes and challenges, so we really want to create awareness and capacity building around viral hepatitis in the context of HIV prevention programs for PWID. However, there was a huge challenge back in 2018 to 2020 where the needle and syringe service stopped for 24 months in eThekwini due to the violation of the eThekwini municipality city bylaws. Through extensive engagement, we managed to reinstate the program. However, we have noticed way after the duration of the closure and there was an increase in infection of HIV, hepatitis B and C because of sharing of used needles amongst the drug-using community. A success demonstration of the feasibility of integration. So there was no additional startup cost due to the integration within an OST program or existing harm reduction program. There is in South Africa a huge issue around limited budget for viral hepatitis services within the HIV programs. And the challenge is that we at the beginning of the program, we came into a stumbling block where we...
I'm sorry, Kalvani. I really need to ask you to conclude your presentation because we are running out of time. Thank you.
Okay, apologies. So just to sum up quickly, we had 4 clients completed treatment who are cured. 14 clients have completed and are waiting 3 months SF12 bloods. Hepatitis prevention was administered, as I mentioned, 121 clients, but really to strengthen advocacy around viral hepatitis within the district, support from local government, etc. Conclusion, the hepatitis prevalence amongst the drug-using community in eThekwini indicates that hepatitis treatment should be prioritized. Viral hepatitis services can be feasibly integrated in harm reduction services and are well received by the drug-using community. And there's a huge need for ongoing advocacy and to scale up viral hepatitis prevention and treatment services. Thank you.
Thank you. We will now move to the last presentation. It's from New York City, and I'd like to welcome Marie Bresnahan. She is the Director of Training, Policy and Administration in Viral Hepatitis Program at the New York City Health Department. She worked previously on the related issues at the American Liver Foundation and was a founding member of the National Viral Hepatitis Roundtable. She has a Master in Public Health, focused on HIV program planning from the City University of New York, and she lives in Brooklyn. I would like to ask you, thank you. Please, the floor is all yours.
Thank you so much. Yes, good morning, everybody. Thank you for these excellent presentations. I'm going to talk a little bit today about the viral hepatitis program in New York City. Not very much focused, but a bit on our epidemiology data. I'm going to really try and look quickly at our public health infrastructure and our elimination plans. Let's see. Oops. Sorry, just 1 second. I might seem to be having trouble advancing slides in that other mode, so I'm gonna just try and show screen in this. Let's see if this works. Sorry about that. So in New York City, what we've determined, I think what other cities have said and what is necessary to really look at viral hepatitis and make change in this area is a strong surveillance system. We're fortunate to have a very strong surveillance system in New York, and other cities in the United States and otherwise have looked at our system to try and build similar ones. But as well, this work cannot happen without key partnerships and collaborations, both internal and external. And clearly, as others have said, the tremendous need to integrate this work into HIV, STIs, and harm reduction programs, as well as with hospital systems and other places. And then there's a critical need to develop a plan for viral hepatitis elimination. So here in New York, what does our surveillance data provide for us? Well, it does help us target neighborhoods with the highest rates of infections. It helps us look at the demographic data to identify populations with greatest risk, and it helps us look at the development of care cascades. So this is where we can track the number or track issues related to who's been screened, who's been treated for both hepatitis C and B, and for C, who's been cured. So I'll talk a little bit more about that in a minute. So what's going on with our data in New York City? We have, if you look at this graph from left to right, you'll see a decrease in the number of newly reported cases of chronic hepatitis B. We see that's 2019 and 2020, which is clearly a product of the COVID epidemic or pandemic. In New York, we have more than 240,000 people currently with chronic hepatitis B. And then hepatitis C shows a similar curve, as well as a pretty sharp decrease in newly reported cases in 2019 and 2020. Again, so many people were not getting care during this time. Again, in New York, we have more than 90,000 people reported with hepatitis C. So lots of data that we collect to look at who's impacted, what are our current rates, and what do we do with that data? We try and use that data to impact individual patients, communities, healthcare systems, and policymakers. And we try and work from individuals up to systems, and I'll give you some examples of how we do that. So one thing we do is really trying any creative way we can find to connect patients to care. So as has been said, we know many patients are screened but not connected to care. People with hepatitis C are screened but not getting on treatment. So we do something we call Tele Navigation. We have staff at the health department that take referrals from many sources. Many of those are shared on this slide. They get referrals by looking for people who are co-infected with HIV and hepatitis C through our surveillance systems. They get referrals from our perinatal hepatitis B program, from correctional health services, as well as the New York City Health Department has sexual health clinics treating people for sexually transmitted diseases and other issues. Those referrals get fed into navigators at the health department that will contact these patients and support them into care, make appointments for them, remind them of their appointments, give them education to understand the importance of getting treated for hepatitis B and hepatitis C. We also have navigators out in the community. So we have community-based organizations where there is funding to provide a hepatitis B navigator or a hepatitis C navigator in a variety of settings. These navigators, as well as peers, all of those peers who are located in syringe exchange programs, conduct outreach, they provide harm reduction services, contact tracing, health promotion, referrals to supportive services, and navigation so that they can complete their diagnostic testing and their hepatitis B or C medical evaluation as needed. And then these patient navigators and peers also support these patients through treatment. As well as that work I just described, working with individuals, we seek to impact healthcare systems. So we seek to promote hepatitis screening and treatment in primary care, as well as community-based medicine, by working with clinical leaders to assess their workflows and create systems change to improve care. So if they have screening systems in place, but they're not catching all the people they should, we help them upgrade those systems. We give them training and technical assistance, and we provide a significant amount of clinical medical education on the guidelines to properly test and screen people for hepatitis B and C, as well as treat them. As was mentioned by other speakers, another critical part of our work is community engagement. So we've developed a coalition in New York City called the Hep-Free NYC. There's really two arms to that, a hepatitis B coalition as well as a hepatitis C task force. They meet separately, they meet together so that community members, advocates, clinical providers can all learn best practices from each other, discuss strategies, connect with each other so that they can create their own strong referral sources. And as part of the Hep-Free NYC, we have various committees. So we have an advocacy committee, which seeks to look at the public health policies and laws and structures around these issues and advocate for increased funding or other issues. We have a research committee. We also have a subcommittee, which is the Coalition Against Hepatitis in People of African Origin, or CHIPO, and a South Asian Hepatitis Initiative that's working with the United Sikhs and other South Asian community members to look at hepatitis B and C in their communities.
Marie, I have to ask you to conclude your presentation, please.
Okay, great. I just have two more slides, which is that what we have done in New York City is create an elimination plan. The elimination plan is focused on reducing the number of Hep C infections, improving health of people with viral hepatitis, and reducing health inequities. I'll go quickly to this last slide to just describe how we developed this plan, which took a good year and a half to finalize this plan and get it published. You can see this plan on Hep-Free NYC, the website. And this plan is just in the early stages of, it was just released last year, so now we're looking at how best to implement it. And as we're looking ahead, we want to really focus more of our efforts on looking at hepatocellular carcinoma incidence among people with viral hepatitis, doing some more work to really finalize this hepatitis B care continuum, as well as looking at issues related to endocarditis and hepatitis among people who inject drugs. So, I'm sorry to rush the end, but thank you very much. Happy to be speaking with you all today. This is my contact information if you have any questions.
Thank you. Thank you very much. We will now move to the panel debate where Jeff will be the moderator. So Jeff, it's with you.
Well, thank you very much, and thank you for the 4 presentations as well as others who are joining us online. We are going to open it up to the floor if anyone has questions or comments, and while you think about that, I just wanted to ask Mark and Marie, so from Australia and New York, a question. I think both Ian and I mentioned how one of the ways we've been able to integrate services with hepatitis C has been to take advantage in a way of the COVID-19 pandemic and combine efforts in that way. And since you both presented on really the amazing work in Australia and also in New York City, but very focused on hepatitis C, I was just wondering, we know how COVID-19 has negatively impacted on hepatitis C efforts, but were there any opportunities to combine efforts in either setting, either that's been done or is being considered? So Mark or Marie, your thoughts on those possible opportunities?
Yeah, I'm not sure that we've leveraged DAA therapy access off the back of COVID-19. We have seen a liberalisation of a range of take-home opioid agonist therapy programs and long-acting BUP and those sort of things. I think we've yet to adapt systems of service delivery and taking advantage of some of those in relation to DAAs. We are working with health departments, however, on some of the innovations that were brought in relation to surveillance, particularly the way in Australia governments were able to access in real time COVID-19 testing and using public health systems in a really responsive way when notifications of COVID-19 came through to facilitate follow-up. And I think that's an area that they suddenly liberalised the sharing of data and allowed the sharing of notifications data to happen much more readily and in real time. I think there are real opportunities there to take advantage of that in relation to hepatitis C notifications as well, and ensuring follow-up is done and RNAs are ordered and treatment is followed up on.
A quick follow-up before I turn to Marie. So I understood from what you presented that you'll be rolling out decentralized testing or diagnostics across the country, and I think that was with the gene expert. As a part of that hepatitis C effort, will you be then using, since that's a multi-condition platform, will you be using that for COVID-19, for HIV, or any of the other infections that can be tested for, or is it going to be focused solely on Hep C? Mark, were you able to hear us? Maybe not.
No, sorry, you broke up a little bit there.
Okay.
Yeah,
So I was asking as a follow-up question, I understood you have a project now to roll out decentralized testing across the country. I think the gene expert will be part of that.
Yes, sorry. Yep.
Will you be including, since the gene expert can be used for COVID-19, HIV and other conditions, will it be a broader ID effort, or will it be focused on your hepatitis C elimination efforts?
No, I think there are plans to integrate particularly hepatitis B testing as well. I think there are plans for pilot work to look at COVID-19 as well. I think it's a slightly different disease, given it's an acute infection that resolves over a period of time. I think the model in which that's being implemented is probably more amenable to chronic diseases and chronic underdiagnosed diseases, as opposed to temporarily acute diseases like COVID. But yeah, there's certainly work that Jason Greberly and others are doing to integrate and take advantage of that broader platform that CEPID offer in relation to other infectious diseases, including STIs as well.
Great, thank you. I think it's important for the world to see how you're doing that, because one of the challenges was for us, largely in sub-Saharan Africa, but here in Spain and other parts of Europe where we have some of the gene experts, we weren't able to get the reagents to test for COVID-19. So it'll be interesting to see if you're able to have that kind of joined up effort, because it'll be an important element of pandemic preparedness, I think, more broadly. And let me turn to you, Marie, really with the same question. I mean, after New York City rebounded from being really one of the hardest hit cities at the beginning of the pandemic, you've showed us, the drop-off in hepatitis C diagnostics and treatment. Have you been able to join up efforts in any way?
I mean, I think it's a complicated question because we went from a COVID crisis in New York. We've just busily been responding to a monkeypox epidemic in New York, and there's potential for polio as well as Ebola spreading around the world. So as so many infectious disease issues are happening, but I do believe with COVID, we sent droves of outreach workers into the community with test kits and masks, and I think having boots on the ground really helped. We have a very diverse community in New York City, and I'm hoping that the fact that the health department was there on the front lines of COVID did help build trust among many of the communities in New York that might not have otherwise wanted to come to a government agency for support or care.
Thanks. And you raised the trust issue, which is why I think some of these joined up efforts can be facilitated, because there has been a lot of trust issues in general with how governments have been handling the pandemic, but often more trust in ID doctors who have been and others who have been engaging on hepatitis C care. So I think there's some opportunities there. And it was interesting when Mark mentioned some of the challenges in Australia. I mean, where you almost have this diagnostic burnout. They've done so well, and it's hard to go the last mile. And now you have Quick Start, and you have the decentralized diagnostics being rolled out. But you mentioned recognizing the competing priorities, and I'm wondering really for any of the speakers, Ian, Marie, Cavanya, I mean, how do we deal with competing priorities? I mean, you mentioned, Marie, that you've great surveillance in New York City. You know which neighborhoods are most affected. And in some of those neighborhoods, ID is very low on the priority list, and hepatitis is not even on the list. So for any of the speakers, how do we deal with those competing priorities?
I would just say we definitely have to integrate this work into so many other things, into syringe exchange programs, into substance use programs, into neighborhood coalitions, into community health care. It seems to me that's the only approach we have.
Thanks. Ian?
Yeah, I agree. Sorry, I was just going to say the data that we have in Australia show that people who inject drugs are actually really frequent attendees at health services. And we just need to take advantage of those points of contact in a much more integrated way.
Thanks.
From my point, I'd go slightly differently, because there's a kind of repeating thing that I see in both HIV and viral hepatitis, which is that I think the community of people here underrates how important their work is. And sort of obviously there's the intent is to say, well, everything we do is important, of course it is. But blood-borne viruses in particular represent a change in pathology over time, which is unmatched in anything else that is happening in medicine. The fact that people with HIV can have completely normal lives now, rather than what used to happen 40 years ago. Hepatitis C can be functionally cured. There are more treatments on the way. It is genuinely exciting to be part of this. And I think because you have the community, you have more, it is more exciting than some other, I won't name the other conditions that I think are less exciting, but I look after a basket of 143 conditions, and these are the 2 or 3 that I really care about, because it's so much progress has been made by a community that comes from advocacy, that comes from tragedy, and has made all this possible. And there is something about harnessing the energy and the excitement of that outside of just, well, medically we can do this, to make it a proper movement, which is kind of where you harness the fast-track cities energy, and that's really the thing to tap into, I think, to make that better.
Thanks. I'm glad you see so much energy, enthusiasm, and excitement. I don't think we could say all the communities would necessarily agree. They're wondering what you're even going on about, and you know what the different kinds of hepatitis are, if they even understand that. But that's what we need to convey. I don't know if from South Africa you have any comments. I mean, you've dealt with such a large HIV pandemic. I mean, how do we get viral hepatitis onto the agenda? I mean, is it, you know, we just dealt with COVID, or we're still dealing with COVID-19, so is it like one more infectious disease? When will you guys go away? Or is it like, let's harness that energy, we did it with HIV, now we're gonna knock off viral hepatitis?
Yeah, no, I think I'm going to echo the sentiments as Marie. We have to be able to, in order to reach the difficult, vulnerable populations, is to carry out services within existing programs and use that integrated implementation data to advocate, especially at, you know, municipalities and local government level. Because in South Africa, harm reduction services are not well endorsed. Harm reduction services are always in the back foot of, you know, integral services that are put forward. So we need to be able to bring forward viral hepatitis initiatives within these programs to advocate the need for it and the need for treatment within the primary public health sector. Treatment is extremely expensive. We can only offer it to a limited cohort. And so we need to be able to, you know, have local Department of Health, as well as national, endorse this treatment and provide it at, you know, public facilities.
Great, thank you for that comment. I wonder if anyone in the audience would like to make any comment or question to the panelists. We have one. I'll ask my assistant here. No, I'll ask you to use the mic just so people can hear online.
Hi, good morning. I'm Ellen Generaal from the Public Health Service of Amsterdam, and I have two questions for Ian, actually. They're a bit more specific, but I was wondering, you did mention you had pretty high uptake of the HEP and HIV testing in the emergency departments, but I was wondering, was there a difference for people that came in for a completely different reason? I mean, you can come there for a broken arm or needing surgery, so I was wondering whether you could reflect on that. And my second question is, if you don't have that amount of budget for your city, but you want to implement something like this, is there like an alternative that you could suggest, maybe doing a pre-selection of people that you test based on demographics, migration background, or risk behavior? I was just wondering whether you would reflect on that a bit more.
Sure. I mean, we test for any reason. So it's likely to be an unrelated reason that you're in the emergency department. That's kind of that's the whole thing of it. So yeah, you could come in with a broken arm. You know, we had a guy who revolutionised care in HIV, who was opt-out tested for HIV, who fell off his bike and didn't know he had HIV, and has now changed the law so that people can serve in the military. So we were going for absolute maximum coverage. That's why it's so many tests. You don't have to come in with a related condition. If you don't have the budget, it's a matter of working backwards from what budget you do have. Some of the technicalities around pathology I won't bore everyone with now, but I'm very happy to talk to you afterwards about how you could do it. But yes, you could do something smaller, yeah.
I'm going to take a last comment from Justine online, and then we'll hand over to Jessica.
Okay, thank you so much. I thank all presenters, and my question goes to almost all. Anyone can respond. And I'm in Rwanda. Rwanda is among African countries that managed to implement and launch elimination program, and we are on good track. Yeah, I want to focus on the scenario that seems to be forgotten. I wonder what happens to people after SVR, because among our presentation, I have never seen someone to mention, because during this time, there are risks of relapses, there are risks of reinfection, for which prevention and treatment guidelines should emphasize on behavior change education and family screening. I also want to mention about the interaction between hepatitis C and hepatitis B, where this has been never addressed in the DAA era, because in 2 studies I personally conducted in Rwanda with the 2 different populations, including general population and high-risk groups and prisoners, I found a protective effect between hepatitis B and C, with those infected with hepatitis C being less likely to have hepatitis B. Here I mean, despite the gender and disparity that has been presented in prevalence of 2 infections, several researchers, among others, Mariana Mavila and Vigan and so on, they have shown the predominance of hepatitis C, which tend to hide hepatitis B until HCV is cured. And that is when only HBV can reappear. Here I can say people would continue to die silently because of that unknown hepatitis B infection. We can still find liver cancer, liver diseases among the so-called cured individuals. I want to see what the presenters or other audience can say about this problem of after SVR12 follow-up. Thank you so much.
Thank you, Justine. I see your hand up, Marie. We'll take a brief comment and then we're going to have to close the session.
I was just going to say that, of course, the need for liver cancer screening after SVR is critical, and liver cancer screening is an ongoing need for hepatitis B as well. And getting funding for that, for the uninsured or for certain populations, is challenging, but something that we all, I think, have to look at to assure moving forward.
Thank you both for that last comment. And you'll recall in WHO's long continuum of care, they do call for continued monitoring, particularly for those who presented late. Let me hand over to Jessica to close the session.
Great, thank you, Jeff. Thank you very much to Fast Track Cities and IAPAC for inviting me to close today's session. So I work for the World Hepatitis Alliance, and for those of you that don't know, the World Hepatitis Alliance is an international not-for-profit organization, and we have over 300 members in 100 countries, all of whom are civil society organizations who are working to eliminate viral hepatitis. And we work alongside our members to advocate, influence policy, and raise awareness to improve the lives of the 325 million people living with viral hepatitis. And so, as we heard at the start of the session, the Paris Declaration commits Fast Track Cities to not just eliminating HIV, but also hepatitis and TB. And so we were really pleased to partner with IAPAC on how we can better integrate hepatitis C into Fast Track City responses. And integrated responses are key. We're not going to reach the 2030 HIV targets or the 2030 hepatitis targets unless we integrate responses. We have to do it together. We're not going to reach either one alone. And that really requires a shift in the way that we think. As Ian pointed out earlier, COVID showed us we can change what we do and we can change it quickly. And so that's what we need to do now to get us on track for 2030. And I think we've heard from our presenters today some really great examples of integrated programs, from Spain, Australia, London, South Africa, and New York City. And so I just wanted to highlight a couple of key themes that really stood out to me. So first, involving the affected community is critical, and this underpins everything. We will not have impactful and effective integrated services without the meaningful involvement of community. And that word meaningful is really important. They need to be involved at every step of the response, and it needs to be hepatitis and HIV affected communities involved in designing integrated programming. The locations for a lot of these integrated programs already exist. We have harm reduction sites, we have emergency departments. There are some really simple ways that we can integrate testing and then the appropriate linkage to care that support the communities and that are at places that people are already accessing. And I think that's really critical. We need to make sure that services are delivered where the people are, not that the people need to come to the services. It is a really, we all know that stigma and discrimination is a huge barrier for accessing testing and care, both for people living with HIV and for people living with hepatitis. And so, framed the right way, integrated services can really help remove some of this stigma. And I think that is a really, incredible opportunity to change the way and really overcome a barrier that, at every meeting, every HIV meeting I'm at, every hepatitis meeting I'm at, how do we move the needle on stigma is discussed, and we really haven't we don't have an appropriate answer yet. So anything we can do to improve that is a win. And also, we need peers. Again, it's all about communities and making sure that people living with hepatitis and HIV are supported, and whether that's mono-infected or co-infected. Integration needs to happen at every level. This is from policy to service implementation to peer support, but it also needs to be funded. And we know that that's a huge problem. There is, the Global Fund have come out with their new HIV information note, which now has expanded support for hepatitis co-infection, support for hepatitis commodities for key populations, and support around triple elimination of hepatitis B, HIV, and syphilis in newborns. And it's really important that countries that are Global Fund recipients take advantage of this. We've seen in other Global Fund countries where they have started with Global Fund funding, they've really gone on to implement great programs and sort of countries that are really championed now as leaders in the hepatitis response. So hopefully this is an opportunity for more countries to take that forward. And finally, I know we're over time, so I will just say that I really hope that next year at the next Fast Track Cities Conference, we have even more cities and countries sharing their experiences of integrated responses and how they're getting on track to reach the 2030 targets for hepatitis and HIV. Thank you.
Thank you. So that's the end of our session. Thank you. think in person we're only 4. 1, 2, 3. Yeah, we're only 3 in person. Yeah. I wouldn't be able to know. I don't have access to the bathroom. Yes. Good morning, Mayor Chun. How are you? Doing well. So we need one more chair. I've done the presentation, but I wanted to introduce myself. Iman Sidibe. I was the one who was supposed to meet you here. Nice to meet you. Somebody here. All right, so let me find you one more chair. Someone. No, squeeze the other one. Oh, okay. That's okay, Mayor. Please let me. You're very welcome. Okay. I think we're ready to start. Good morning, everyone. Oh, we've got a few folks coming in. Good morning, everyone. Thank you very much for being here this morning. So for the next session that we have here is we're going to be hearing quite a few case studies from our colleagues here in various fast-track cities in Africa. So yes, with that, because we are a little bit late, we'll get started directly. So we will be hearing from our colleague from Johannesburg first, Fefu Charles, who will be presenting to us today. Over to you.
Thank you very much, the program director. I would like to greet everyone who are in the room and those who are online, if there are other online. So my name is Charles Mpepu. I will be presenting this case study from Johannesburg, South Africa, and then the background of, where is that? I will start with the background of HIV. In South Africa, 47% of people living with HIV live in the city across the country, and then civic society are working tirelessly to improve the health outcome of the community at level. And the Men's Forum, the City of Johannesburg, through the Takwandime Foundation, men's movement, have been implementing behavior change initiative targeting men and boys. As you know, that men and boys are always left out. And then the goal is to address the social and structural drivers of HIV and STD infection. This initiative is linked to implementation of Goal 4 of the National Strategic Plan, NSP, on the HIV and AIDS and STI 2017 to 2022. And then if you look at the pictures, this is what we're doing as a community. Whenever we go, the community, they come in because this is a community initiative. So in terms of the background there, this initiative was, the concept was done in the one township, which is Alexander. And the Alexander is the oldest township with history dating back more than 100 years. Intended population is plus minus 700 people. And then 10 of the 30, it's one of the 30 hotspots in South Africa. So background in gender-based violence, as you know that there are drivers to HIV. We're dealing with the root causes of gender-based violence and also the HIV. So the background is 51 women experience GBV, 51% of women experience GBV, 54 increase in GBV cases in lockdown, during lockdown, and 12.1 in 100,000 women are victims of femicide. 1 in 5 violated by partners, 53.293 reported sexually offenses, which are the risk of HIV, 5 higher rate than globally, and then 9.6% of women reported being sexually violated by another man. Those are the MSM. And then South Africa has one of the highest level of GBV in the world. GBV is sexually and domestic violence against women and children. And Men's Forum, through the program of #NoExcuse, is educating and mentor boys and men to improve their awareness and understanding of their roles in society and how to coexist positively with women and children. On a weekly basis, the Gang for Good, they meet to discuss and take a stance against HIV and gender-based violence in the community. Also, the television and the radio appearance helps spread the message across the country. So the approach that we take is that we initiated this on 2018, and the Men's Forum recognized that the shift and effective action is required in order to address the violence against women and children, especially as GBV is violated of human rights regardless of where it occurs. Using a multi-stakeholder approach, the Men's Forum in Alexander Township examined the GBV and increased prevalence of HIV and AIDS amongst men and boys. Various stakeholders, including police, health promoters, traditional practitioners, counselors, organizations, NGOs, CBOs, and other partners are mobilized to support the different campaigns initiated by the Men's Forum. So the Men's Forum has estimated registered membership of 1,600 men who volunteers their time to mentor other men and boys with a multi-program prolonged strategy. The Men's Forum focused on awareness campaigns and community targeting men and boys to prevent new HIV infection, as well as to reduce the violence against women and children. The example of interaction include radio calls in where anyone can ask for confidential health important of HIV testing and treatment, as well as prevention for GBV. Appearance on local TV and community workshop and other arranged event. So what's happened is that we have a WhatsApp number where when they listen on the radio, we provide that WhatsApp number to talk about confidential information. If they were returned from taking treatment, then we come in to assist. And those 1,600 men and boys who are the mentors around Alexander are engaging with those men and young boys in terms of dealing with structural and social change. During the past 2 years, the Men's Forum has proven to be impactful despite no funding to expand its impact. This project requires funding to provide additional resources and roll out as proof of concept that was proved in Alex. The statistics for the Men's Forum reach summary of those statistics in gender-based violence dialogue. We reach school boys between the age of 12 and 18, 600 boys. The youth 18 to 35 are 2,000 men. Adults and men above 35 years, above 35 years are 1,500. Older person above 50 years are 50 men. Tested for HIV between the young people age 18 to 35 are 8,000 men, and then 5,000 women, and then 500 women. Adults above 35 years are 700 men. Children, older person above 60 years are 30 men. The referrals for young people are 300 men refer to services, and then 70 women refer. Adult over 35, 200 men refer. Children and person above, older person above 60 years are 10 men. So the other activities that we conducted is like the tavern intervention. Those tavern intervention is where we go because we are not waiting for men to come to us. Where men are, like at the tavern, we go to the tavern and engage with those men and talk about those issues that they don't want to talk about. Like that lead them, because we wanted to understand the root cause of GBV and femicide. And at the tavern, we reached more men, because when we said our target is 100, and then more than 140 men, they come in, and then supporting via the WhatsApp group, because we don't leave them behind. On that WhatsApp group, we add everyone so that we continue to engage with them. And then 264 men, and also we provide the intervention if they need food passes, because we are working collaboratively with social development and other NGO. Where we see the need, we engage and refer those people to receive those food parcels. And today, 1,600 families receive food parcels. And then we promote also vegetable garden, where 34 child-headed household, they benefited from the food gardens. And then in terms of HIV treatment and re-initiation, where we find 40 men were referred to re-initiated, because most of them, they come from the jail, they don't know where to go. When they go to clinic, they tell them about the demarcation. Somebody who come from the jail, they don't understand even issues of demarcation. So we take them handed and go to them to the clinic. And then 40 men we re-initiated, and 60 women. And the Men's Forum strategy embodies social and behavioral change model, which incorporate the following range of approaches. Activism. As an activist, we promote that we talk about those language, because if we don't talk about health and HIV, we can't be an activist. So activist advocacy, we advocate for those issues of health, and then community mobilization, where we mobilize community to access the clinics. Community education through community call-in radio station and newspapers. In the newspapers around Alex, even when I'm here, the newspapers was reporting that I'm here, and when we go back, we're going to share with them so that they get this information that we need to fast track. By 2030, we need to get to zero infection. The networking with community stakeholders, we brought all stakeholders in the community so that we talk the same language as a community initiative. And then also, we did also the informal research. And then on the informal research and campaigns is where we find out that what we need to do, it need to be aligned with the needs of the community. And then we conduct the campaigns. On the campaigns, as we talk about the Alex FM, if you look at the pictures, you will see that I'm there. In Alex FM, every Wednesday, we are at the radio talking to the community, and then the community, we give them the number and the WhatsApp. And then we also have, we conducted the march on the 9th of August, which is Women's Day, for men to stand up and support and stand up against gender-based violence, where more than 1,000 men comes in and stand up to support. If you look at the picture there, it explains all. And then...
Apologies, Charles. We have a little less than a minute.
Okay.
Thank you.
Thank you very much, because on the pictures, it explains everything. And then activities are daily men's and boys mentorship. And then we also have the Healthy Lifestyle Fun Walk, the support group for people who are on parole, and door-to-door campaigns, including hostel intervention, sport and recreational men and boys camps, and then workshop. And then the research also, there are research findings and the lesson learned that we also discover. And then for those are the pictures there behind me, so that I thank you very much.
Thank you very much, Charles. I know you're running to the airport shortly, so I would like to give an opportunity for a quick Q&A, if my other colleagues here will give us a few minutes before Charles needs to go. So I'm opening the floor for any questions. Okay. Yolanda, do you want to help? Thank you.
Thanks, Charles. Thanks for a good presentation. I work with Charles in the same city. I just wanted to check if the same model is being used within the city in Wetkoppen or any other, because it's a very good model.
Thank you so much. I think it's a very great program, but since I'm a South African and I know that we are the hub of gender-based violence and men are perpetrators of gender-based violence, how do you, in your membership, how do you make sure that you don't find yourself in conflicted spaces of men running to join the network, whereas they are actually using this as a nest to hide and still coming back and advocating to say we are against gender-based violence? I find that the spaces that we've created in community settings at advocacy level, from SANEC Men's Center right down into community level, we still find ourselves as civil society in the very same spaces, pinpointing at each other, and men going to hide in such platforms and coming back and wearing a different t-shirt. How do we make sure that we screen? And I guess I'm asking a very socio-economical, political question, but at the same time, it's a very about behavior and the true DNA of men as agents of change in the country.
Thank you. Oh, there's another.
Thank you. I'm Rose Nyirenda from the Ministry of Health, Malawi. It was a great presentation. A number of best practices that we can learn from. I just want to know how you target the elite men. Are there any specific interventions for the elite men?
Yeah. Oh, okay.
Thank you. Just very quickly, we know we have some challenges in South Africa around discrimination against migrant populations, and I just wondered how the migrant population factors into the work you're doing within the men's sector.
Thank you. Can I go on? Okay. The number one, I'll start with the model, because we started this model in Alex. Because we, as a men's sector, we can pilot before we look at the model, how it works, what didn't work, and what it works. We've done everything. Now we understand how can this be piloted to all the 7 regions in the city of Johannesburg. So number 2, how do we make sure that those men can hide on the membership? So what we did on December this year, last year, December, we launched the center where we called it a GBV Walk-in Support Center, where a man can just go there, get somebody to talk to. The lifeline is there to provide counseling, because we understand that healing is a process. We can't just heal today. So it's a process. On that process, it needs other stakeholders like Institute of Healing Memory, where they take men to the camp and go through the mental health issues, and they take men and boys also to the camp also. So we take different age group to the camp, because we understand that we're learning from those who passed those experiences and telling their story. At the camp is where they share their story, because every story needs a listener, and then that listener, that story can help other person. This is what we do on that model. And then the other question, how do we target? In terms of this strategy, we understand that for the past decade, there's no space for men to just walk and get healed. All the time, they were told that men don't cry, you just bottle up in, you don't cry. So this space, we created that we target everyone. And then by so doing, if I start telling my story, the next person will even able to tell his story on a safe space. So creating that safe space is only one in Alexander. So we think that if we can pilot it around, it's going to save a lot of people. So in terms of migration, the question that you ask, when we go there, when we call men, we don't identify intently whether you are a police, whether you're a teacher, but when you come in there, you are a man. We talk about men issue and we don't discriminate. Everyone is in there. I remember there are a lot of men from other countries because those people, they have relationship in South Africa. They got children, they got wife. So we can't treat them outside. We treat everyone. In terms of accessing the health services, they come to us and said, I was denied access to the health, and I take them hand directly. So we take them to the clinic and check who's returning them, because this is the access to everyone. Health is a priority according to the Constitution. Thank you.
Thank you very much, Charles. I know you'll be running to the airport, but thank you for taking the time joining us today, and thank you everyone for engaging and asking some questions. So next we're going to go with our colleague from Kigali, Rwanda, sitting next to me. So Mr. Karangwa Francois Xavier is going to be presenting the next city study.
So thank you very much. Even I can use this press. So we're going to present to you knowledge, practice and inclusion for people with disabilities in Rwanda in the HIV and the sexual reproductive health. It's a study which was conducted by UPHLS under sponsorship from the UNAIDS Rwanda. So quickly, UPHLS, it's a number of organizations of people with disabilities, which is composed by 13 members organizations, which are organizations of people with disabilities. That it's about our vision to have an inclusive society where we have a person with disability empowered and enjoying the well-being and the dignity, while our mission is to capacitate members and partners on disability inclusion. So that is our logo. The study, it was done this year, 2022. It was a CAP study on HIV and SRH among people with disabilities in the city of Kigali as well as the secondary cities. Secondary cities, they are those in blue, meaning Nyagatare, Rubavu, Musanze, Rusizi, Huye, and Musanze. So in Rwanda, we have a total of 30 districts, and those are 6 plus the city of Kigali, composed by 3 districts. They were the one we used for this research. Why this research? You know that the UNCRPD, the United Convention on the Rights of People with Disabilities, in its Article 25, is protecting the health for people with disabilities. So those are the number of people with disabilities in Rwanda, according to the last census. It's not well updated. Currently, we are doing another census. Those data are from 2012. And we use a method and the research design as a cross-sectional study design, where we use quantitative and qualitative methods. During the data collection, we use face-to-face interview and the focus group discussion with the different people with disabilities. And we respected the process by having the approval from the Rwanda National Ethics Committee. For the sample size, we estimated that around 120,000 people with disabilities are in the city of Kigali and the secondary cities, and we select 466 persons with disabilities grouped in all categories. Mainly, as you can see, they were, sorry for the technical problem, but mainly were for with the physical, well, yes, it's a result. Mainly, the mainly were participants with the physical impairment. We had also hearing, visual, intellectual, as well as other categories of disability, like people who have a combined disability. So the sampling strategies, we use 30 administrative sectors. In Rwanda, we have from national, province, district, sectors, and cells. So we selected from the sectors by looking from the rural and the city. And 16 participants were selected randomly from each sector, and we conducted an interview at the health centers using an inclusive communication, meaning to be friendly, we make the data collection in a way that they are disability friendly to all categories. And the response rate were at 95%, which is 443 out of 466. So quickly goes to some of the results. On the age at the first sexual intercourse, as you can see, we have variables grouped like age group, like gender, like residence, like education, like occupation, and the type of disability. So maybe here you can see that most of them had the sex between 18 to 24 years old, and most of them, they are the one who are in the vocation on ordinary level. And you can see different data collected from the research. About first sex at the first sexual intercourse, so you can see that the big challenge are for the hearing and speaking disability people. Why? Because most of the time communication with the hearing people without sign language, it became a challenge, and people used to use force to have the first sex relationship. And when you can go to the commercial sex in the last 3 months, so we found that among people with the disabilities, we have also female sex workers, and it was also by curiosity that we have also men who have sex with the men among people with disabilities in the Kigali city. So as you can see, the residents in the Kigali city, we have 12.2, which is the first one to have the commercial sex workers with the disabilities. That it's normal. Commercial sex working is most in the city than in the rural area. About the number of the sexual partners, where we had those who have the one only spouse relationship, those who have a regular and no married partner, and those who have a multiple partnership. So where we found that still it's a big challenge for the hearing and speaking impairment people. Why? Because most of the time we have what we are calling the deaf culture. They are open to tell what they did, and still the barrier of communication became a challenge to get, which pushing them to have multiple partners in sex. So about the condom use at the first sex, we found that it's a good situation, because if you can look for the age group, the challenge is for those above 50%, where they use, it's on 91.4. When you go to the knowledge about HIV transmission, the use of condom, how HIV is transmitted, and so we found that different data, but here we can say that at least the age between 25 to 49, 96% they know that a person apparently good health can transmit HIV. When you go to the attitude toward the people living with HIV, people with disabilities in Kigali and the secondary cities, they are not stigmatizing person living with HIV. When it goes to the knowledge on ARVs and the PMTCT, so the knowledge is not really good. Most of the data are in the range between 50 and 60, so which is a challenge because it's not 100%. When you go to the utilization of HIV testing services, also in the last 12 months, generally around 50% were tested, were using the HIV services. When you go to the HIV prevalence, we found that in the city of Kigali and the secondary cities, HIV prevalence is higher than the general population. So we tested around 411, which is 411 participants, which representing 92% of the total responding, and the prevalence were around 7% if you do the mean. And regarding the VMMC, we found that most of them, they are the percentage is too low compared to the general population, especially for those who are 50 below, who are above 50 years old. So about the knowledge on SRH, the data, it's not too bad, but we are still having some categories to improve. Regarding the family planning, I can say that it's the same. Quickly about the support to the respondent level of satisfaction, it's on support from the family members at 35%, they are satisfied. So going to the conclusion quickly, I have a short time. So we can say that in the conclusions, the comprehensive correct knowledge of HIV is deficient, around 30% among people with disabilities in Rwanda. We can say also that people with disabilities in Rwanda, they have a positive attitude toward people living with HIV. Why? We can say that sometimes HIV and disability, they have a kind of relationship. All of them, they are facing a stigma from the community. And 66% of participants had a comprehensive knowledge on IRT and the PMTCT. So while 94% of the response believe that the contraceptive method can reduce unwanted pregnancy, while almost 92% would use family planning, while only 29.8% use family planning in the survey. So the last one, HIV prevalence among people with disabilities is too high. I'm saying that because the research showed that 70% of people tested are HIV positive, while the general population is 3% in Rwandan context. Even it was in the city of Kigali and the secondary cities, but it showed that it's very high, so we needed to make like a national one. So we recommend some recommendations quickly, including like to improve the physical inaccessibility. Rwanda is geographically composed by hills, so we needed to improve how our health facilities looks like. We needed to include a disability-friendly service package, where we developed even a guide, a disability inclusion guide we can share to you. So we needed to increase the knowledge of healthcare providers from the community level up to the hospitals, and we needed to increase the awareness to address social norms surrounding disability, which results stigma and discrimination. On the planning and the policy implementation, we have to include the disability indicators in national reporting system, HMIS. So we needed to incorporate disability MN tools and the system for individual and aggregated data, such as the HMIS, Health Management Information System, and we needed to involve people with disabilities in all aspects, from planning to the programming, because we were saying that nothing for us without us. So lastly, we needed to assess laws that, if laws protecting people with disabilities, if they were implemented. Finally, we have to equip the organization to monitor the implementation of the guideline on the inclusion. Maybe my colleague Gatete will show you that disability inclusion guideline. It's a document that we develop. Maybe we can share to you via email. So we thank you very much for your kind attention. Maybe if you need more details, it's on our website. So you can Google, you can look on it, then you share the information. Then you can make the same in your different cities. So thank you very much, and God bless you.
Thank you very much, François Xavier. We'll have a chance for Q&A at the end of the session once everybody else has presented. So the next presentation is from our colleague in Kampala, Uganda, I think, who's joining us virtually today, Mr. Christopher Oundo from the Kampala Capital City Authority. Christopher, are you online? Hello? I don't think Christopher is online yet. Okay, in which case we will continue with my colleague here from Lagos, Nigeria. So Montserrat Adeleke from the Lagos State AIDS Control Agency. Over to you.
Thank you very much. Yeah, I see my slides. Okay, so I'm going to be making this presentation on behalf of Lagos City, Nigeria. So I'm going to be talking under the background, the city epidemiology, our findings, the success stories, our challenges, and the conclusion. So basically, Nigeria is currently having the highest burden of vertical transmission of the HIV, which is about 22% of the HIV infections from mother to child. But don't worry, we're working on that, and we're getting better in Lagos. So the success, of the prevention of mother-to-child transmission of HIV is totally dependent upon if we can get a high retention of mother-infant pairs within our programs. So the effectiveness of this prevention of the mother-to-child transmission in Lagos has brought a significant reduction in the burden of, the maternal mother-to-child transmission. So basically, Nigeria, the epidemiology, we have an estimate of about 8.5 million pregnancies per year. Of these people, 67% of them have access to antenatal care. You would see that it's only 39% of them that actually deliver in our facilities. Only 43% of these women now have access to the PMT services that we have. So we have a huge gap of about 57%, for these women who require our PMTC services. Now, what we have seen is that we have an estimated number of pregnancies of these pregnant women from 2020, 21, and 22, and we're working with them. So we did a pilot structure, and what did we do? We piloted this in about 10 LGAs. We have 20 LGAs, which are like municipalities. So what did we use? We used about 51 of mentor mothers. They were engaged for this year, and we carried it out in 2021. So what did we also target? We used about 31 high-volume centers where we carry out our antenatal care within the community structures. So we used traditional birth attendants, we used the faith-based organizations, and we used our OVC, the Orphan and Vulnerable Children Program. So those were the targeted group that we used. So what did we have? We looked at pregnant women that were counseled and tested that received results versus the HIV positive mothers. So basically, if you look at it, we were comparing them in the TBAs, that is the traditional birth attendants, using it with the orthodox, the facilities that we provided. If you look at it, we had about 64 positive people. After all, we tested about 45,009 in the TBAs. We also had 276 positive people in the orthodox place, but with a higher number of testing of over 61,000 people. So you'd see that in the next slide, we had a positivity yield for the TBAs. The positivity yield is about 0.14%, and in the orthodox, we had a higher, which was about 0.46%, which is, not bad, because at least we have a more holistic approach in the orthodox facilities, so at least we're able to bridge our gap. So if you look at the contribution of new HIV positive pregnant women in the community structure, you'll find that if you look at the one for the traditional birth attendant, we have a contribution of about 18.2%. In the orthodox facilities, we have a higher contribution, which is about 81.8%. So this is good for us. When you look at the community structure's contribution again to our antiretroviral prophylaxis for our HIV-exposed infants, you'll find that in the community structure, we still have it high, which is about 31.52% with the TBAs. And we have in the orthodox facilities, which is about 64.48% too, which is quite high. So when you see our coverage, like I did say before, we have one of the highest burden and poorest PMTCT coverage. But when you look at what we did in 2020 against what we've done in 2021, you can see that we're coming up slowly but surely. We used to be like 28.3% before. Now we're getting better to about 34%. So what's responsible for all of this is the best practices that we've managed to do. We will see that we're now reducing the PMTCT ART coverage gap. So at least we're making sure that we put all in place to make this better. We're decreasing the HIV testing missed opportunities during the ANC because we have more facilities being patronized. We're also achieving 100% linkage of newly HIV positive pregnant women, and we're linking them straight to our PMTCT program from the community structures, especially using the mentor mothers. We're able to do that. Then we are also ensuring that we're improving the child follow-up, the ARV prophylaxis and early infant diagnosis from the HIV-exposed babies through these mentor mothers as well. We're able to improve our collaboration between the community structures and the orthodox health facilities. We continue to build the capacity of the traditional birth attendants. In Lagos, we have the cultural beliefs and norms. They really believe in TBAs. So what we do is that we continue to empower them. We build their capacity. We sensitize them so that they recognize the danger signs of pregnancies. Immediately they see a pregnant, positive woman, they know what to do, and they link them to our services. They also do the testing. Oral self-test kits have been given to them as well. We have also managed to increase immunization coverage for these HIV-exposed babies, especially through the Mentor Mother program. It's been really successful because it is a story of for us by us, as in we've been there and it's not such a bad thing. So we've been building the capacity, especially of these TBAs, like I did say, even on universal safety precautions. So they know what to do, and we continue to do this. We've also had success stories of empowerment and skill acquisition for people living with HIV. We've done a deep mapping of community structures so that we have a full scale-up of PMTCT services in Lagos State. One of the challenges that we've seen is that of the fact that there is non-disaggregation of our national monitoring and evaluation tool to capture the community linkage of our clients to the facilities. So basically it limits the identification of the positive pregnant women that are in care linked from the community structures. So at least we're talking to them about that. If they can do that, we know exactly where we are and where we need to go. So in conclusion, despite the relative equitable spread, that of public healthcare system that we're doing within the city. A large proportion of our pregnant women still patronize these TBAs, and, because of what I said before, of their cultural beliefs. So what we're doing is that we continue as a city to collaborate with these TBAs, the maternity homes, and all our community structures, just so that we can identify the HIV positive pregnant women and adequately track them to ensure that there is a mother to infant pair until the final outcome. So I think with that, we'll be able to achieve and improve our PMTCT coverage in Lagos City. Thank you for listening.
Thank you very much. Next, we have Mayor Chilando Chitangala, sorry for the mispronunciation, that will be presenting for Lusaka, Zambia.
Thank you.
Thank you very much.
Thank you very much. Good afternoon, everybody. My name is Chilando Chitangala, the mayor of the city of Lusaka. Just a little bit, Lusaka is in the southern part of Africa with a population of almost over 3.8 million people, a lot of urbanization happening. The population for the country is almost 20 million now. So you can imagine that's about 20 to 25% of people living in the city. And we are not just alone. We have a lot of migrant friends from Central, Eastern, and part of the southern part of Africa also migrating and coming to live with us in the city. So just a brief background so that you see how much we need to work together to sort out some of these challenges that the city is facing. Lusaka City has a prevalence rate of 15.7 and is one of the cities with a very high HIV burden in in Africa. It is against this background that in 2018, okay, in 2018, Lusaka was one of the priority cities selected under the Fast Track Cities project. To contribute to the reduction in the new infections, Lusaka City initiated Eliminating Mother-to-Child Transmission project. This was due to the high vertical transmission rate, which was at 3.3%. But remember that this survey is only in the 5 communities that were being supported by IPAC and UNAIDS. We have other numbers that are at national level, but this particular survey is done with Lusaka City as a municipality. Lusaka City engaged network of, Lusaka City engaged a network of Zambian people living with HIV. These are support groups that were attached to health facilities to identify pregnant females living with HIV that defaulted on treatment and would be returned and return them in healthcare. So really our case study is about the mother-to-child transmission in our communities. So what we used as a council was a bottom-up approach so that we could just have health workers or volunteers that live in the city with the people. We found that it's much easier for people to trust the people that live with them in the communities. And for that reason, when we visit these facilities and hear their story, the stories of the volunteers, it's, they have a lot of work where they have to identify these women right there in the communities and also work with the volunteers at the clinics that we've identified in those communities. And part of that is empowering of these women who are living with HIV by having certain activities. And these are training them on EMTCT, training them in project proposal preparation, and report writing. So these volunteers or the people that we're working with, we have to train them in when they are going out in those communities, they have to learn how to prepare a proposal and just do report writing. Financial management training as well in these communities, just to keep the women coming and just to make sure that they are independent, because most of them, remember, they are coming from abused homes and maybe they're single mothers and so on. So they need to have a safe house, a place where they know that when they go and tell their story, or when they are identified, they are not stigmatized but encouraged that they could go back on treatment, and also help them, especially if they are pregnant, how to handle it and go for antenatal, and make sure that when they have their baby, the baby is also healthy. So for these empowerment activities, there's an incentive that is like almost close to $2 per day for the work that they've conducted. But we also encourage them to do little businesses. It's just that I brought a sample of my my carrier, my tablet, little pouch that I bought from them that I wanted to come and show here, made out of the local material that we call chitenge. They actually do such beautiful things. So we encourage them by going to sell those things, and then just encourage others so that they know that they have a safe place, because when they go back home, you know, they go through so much. And also just to help them support the little children that are giving birth to. So community activities, identifying pregnant women living with HIV from the health facilities register. So we work with other health facilities that are bigger or at district level that will give us names or people that need support. And by using that process, we go back to the community and identify these women and encourage them to be enrolled in these programs. Tracing, defaulting pregnant women living with HIV through phone calls and home visitations. Home visitations are the best because only one-to-one is easy to encourage another person to get back onto taking their medication, or to go to health facilities so that they get help when they're expecting their baby. Conducting home visits to mothers and infants to ensure adherence to treatment. So these home visits also include the aftermath or the afterbirth, where these health workers now keep going back to the women, encouraging them and making sure that these children are breastfed properly and taken care of, and then after that they're only tested after birth, they're only tested 18 months later. And then sensitization of community also, it involves male involvement in antenatal programs. For those men that are at home with their wives, we encourage them to take part in the involvement of antenatal programs, focus groups, group discussions, and program performance. Men are also very important in this because they also help sort out this problem that we are having. So some men they don't want to encourage their women to go to the health facilities for reasons that when she knows she's HIV positive, they'll be stigmatized as a family, or she'll tell her family and they'll have problems. So sometimes they discourage that. But then you have to teach men that this is okay. They can also get treatment together with their partners. And also when you have these discussions, we also use drama performances of people that live in the community, the people. The message is clear. The message is better when they hear it from their own. From a total number of those that we were working with in these 5 communities, we have a total number of almost 1,300 pregnant women living with HIV who had defaulted and now are on treatment and were tracked to return on care. And 95 exposed infants were tested, and they tested negative. Like I said, they test them from birth. They test them when they are 18 months. Reduced vertical transmission among 0 to 14 from 3.3% in 2018 to 2.7%. That was of last year in 2021. The community groups have continued to link women living with HIV to treatment and provide adherence and psychosocial support in dealing with stigma and disclosure. Stigmatization is still there, but at least now the numbers are okay. But working with them, myself as a local leader, I have seen how most of them, it's been easy for them to come out and seek help because of the community volunteers that we have and working together. And obviously, IPAC and UNAIDS have always supported the local leadership. So councillors have capacity building so that when they are in those communities, they can identify these problems and also call meetings. Because remember that the councillors, the local leadership, is the closest to the people. So people tend to trust that person more than their members of parliament, because their members of parliament are always in parliament, so it's safe. But for us, we are directly linked to these people, so they trust us more. So we've gone through capacity building, especially when you are elected, when you're newly elected, UNAIDS and IPAC come together and train and also orient the local leadership on all these issues. So it's worked out so much that we've involved the local leadership and also trained that they can call meetings, they can also intervene in these groups that are volunteering on HIV and AIDS program. More women living with HIV volunteering are part of this initiative. So that's about it. Thank you.
Thank you very much, Lord Mayor. Next, last but not least, we have Landam Shea from Recap Plus, Yaoundé, Cameroon, joining us virtually. Welcome, Landam.
Thank you very much for linking up to Yaoundé. Good morning, good afternoon, anytime that this may reach you. And thanks for this opportunity to present our project finding on community-led monitoring. Hello, are you people getting me?
Yes, we can hear you, Landam.
Okay, thank you very much. So we'll be discussing on improving quality and equitable access.
Sorry, Landam, but we cannot see your slides. If you could make sure you share them.
Okay, exactly. Okay, let me just do that, please.
If not, if you would like, I think we have a copy of your slides here. We can share them, and if you say next slide, I'm happy to move through them for you.
Oh, okay, thank you very much. Okay, okay. We share it.
Okay. Okay, perfect.
Okay, are we there?
Yes, we're ready.
Okay, thank you. The first slide is just an introduction, improving quality and equitable access to care through the rollout of HIV user-fee community-led monitoring program in Cameroon. It should be, we're doing a case study of the city of Yaoundé. Slides. The next slide, please.
Yes, I'm here. Just keep moving, Landam.
Okay.
I'll move.
The community-led monitoring, CLM, is a USAID, a United States Agency for International Development funded initiative, which was launched on the 10th of August 2021 in Cameroon. So the purpose of the implementations of the users fee policy and the policy and the beneficiary satisfaction on care and the quality of care. So it should be noted that in order to respond to the barriers of accessing health care by the population of people living with HIV/AIDS, the government of Cameroon enacted a policy to eliminate fees charged at health facility for the provision of some HIV care treatment services, such as HIV tests, biological tests for HIV women, CD4 and viral loads, sputum tests for TB, and antiretroviral drugs. It is thus in this regard that this community-led monitoring was set up to ensure the effective uptake of this policy by health facilities. It is currently rolled out in 400 health facilities across the nation by the National Network of Associations of People Living with HIV/AIDS, RECAP+, which I happen to be the executive director. In the city of Yaoundé, the activity is conducted in only 46 health facilities and involves 21 site monitors who are mostly people living with HIV/AIDS and in 6 community-based organizations. Slides, please. So we are talking about some of the activities of the CLM, which is the first is community sensitization. As you see in the picture there, this is a community of people who are receivers of care in various health facilities, and we also try to talk as much as possible to healthcare providers, all with the objective of making them adhere to this policy. We also have development of sensitizations on mobile applications for the anonymous denunciation of the malpractices on users' fee policy implementation at all health facility level. This application has been put at the disposal of the community for even in the communities where CLM mechanism is not yet implemented. Slides, please. We equally have monthly on-site data collection to inform program indicators. And let me tell you that some of these monthly site visit collection of that, data from health workers and also beneficiaries. Some of these indicators include the proportion of health facilities adhering to the policy and health personnel aware of the policy, as well as the proportion of people living with HIV/AIDS who are aware of this policy and those who paid for a user-free services. Reasons for payment of free services by beneficiaries are also being collected as an indicator. So the findings of these data at the end is being shared with various stakeholders and all the health pyramids, beginning from the health districts, the health facility, health districts, the regional, and at the central level. We see slides of workers working in the field. Next slide, please. Then for the results, preliminary findings from the first semester of data collection, that is October 2021 to March 2022, indicate a great interest. 99.6% of health workers who are aware of this policy. This could be as a result of continuous sensitization by the CLM mechanisms. We also have an overall increase on the proportion of people living with HIV/AIDS who assess this policy for this quarter, and improvement from 67% to 87% in Q2. So over 13 communities groups of at least 25% were greatly reached and mobilized, sensitized up to the way they were able to empower them to claim for these services when they visit health facilities. So advocacies done to leaders, mainly to on permission to access site for implementation of CLM activities. It wasn't easy to intrigue some of the directors and district medical officers who were not aware of this government policy here. And it was the role of RECAP Plus agents to make sure that they share the ministerial decisions with the authorities, health authorities. However, slides please. So we, in the course of this activity, we identified talking about the beneficiaries of this project and achievement, we identified some major issues, like a certain hospital, like the military hospital in Yaoundé wasn't applying this policy. So because of great advocacy and discussions, about 11 services out of the 13 are being offered free of charge, but for full blood count tests and blood sugar tests, that the price has been greatly reduced due to the advocacy. We can see a meeting with our local CBO discussing with the director of the military hospital. Slides, please. We equally also identified some stock out of medical booklets in one of our health facilities in Yaoundé, Efuland, and we did advocacy, and this booklet was really printed and made available to the users of care who visit those hospitals. And we equally, in the quality of services, there was poor reception of people living with HIV/AIDS in the hospital. And because of lack of financial motivation, you see, with the discussions with the director of the Efuland District Hospital, we're able to convince the district medical officer and the chief medical officer to share the reimbursement, because these services are offered free, but the government of Cameroon is reimbursing them. So when the reimbursement comes, they make sure that they share it with all the staffs of the hospital. Slides, please. So other problems were still in one of the military hospitals, the Brigade de Quartier General, where there were some indirect payment for viral load, buying of groups and tubes. So when this came to the attention of the local NGO that is taking care of this activity there, they had to meet with the various with the hospital authorities to see that they lobby and convince them, and this indirect cost barrier was really removed. We equally have problems. Slides, please. We equally have problem at the Kwabang Baptist Hospital, where the users' fees were not really implemented. So because of constant sensitization and discussion with the hospital administrator, you see that most of these services became free. The cost of biological tests for pregnant women were really reduced. So some of the major achievements of this community-led monitoring for eliminations of out-of-pocket payments for people living with HIV/AIDS in the Yaoundé city. Slides, please.
Mr. Landon, we have a little less than a minute.
Wait, let me just go very fast.
Okay.
So some of the achievement was the production of communication materials. We produced more than 5,000 communication material to sensitize both the health workers and equally the people living. We also had to engage the media personnel to carry out sensitizations in their various communities. So we had all, slides please, we equally had online platforms for sensitization of people living with HIV/AIDS. You have your slides there. We have a website and also a site to denounce bad practices in various health facilities. I cannot end up this presentation without giving some good lessons learned, which means that good collaborations with the Ministry of Health greatly improve the implementation of this policy, and building the capacities of CBOs equally enhance health decisions making. The last slide, please. So in conclusions, the evidence from the city of Yaoundé has shown that community-led monitoring activities have a potential to improve the quality and access to health care services for people living with HIV/AIDS. It is a simplified model for ensuring community participation in policy formulation through prompt identification of problems and advocacy for change at all levels of the health pyramid. And lastly, there is, however, an urgent need to scale up this activity such that it integrates most health facilities offering HIV services and care in the city of Yaoundé. Thank you very much and for giving this opportunity to present the community.
Thank you very much, Mr. Landam.
Yes, thank you, sir.
Thank you for joining us virtually. So I do know that we've run out of time, but we do have a couple minutes for questions and answers. So yes, we'll be circulating the mic, and I think I will do so now. I'm happy to do so.
Thank you so much for presenters. My name is Jean-Marie Vianney-Gatete. I'm from Rwanda, Rwanda Interfaith Council on Health. It's a number of religious organizations on health promotion. I have two questions, goes to the mayor of Lusaka. Regarding the high number of prevalence of HIV in Lusaka, how does the city engage the civil society, especially religious network, to reduce this high number of prevalence in Lusaka? The second question, regarding also to the prevalence, 15%, it's a high number. How do you deal with the mental health issues related to HIV, people living with HIV? Thank you.
Thank you and good morning. This is Matlodi from South Africa. To the Mayor of Lagos, just for understanding, what was your baseline transmission rate? So the 22%, is it current or is it baseline? And also on the 100% linkage, you did mention the cultural beliefs as one of the barriers. So what I want to understand is Lagos doesn't experience a mobile population in terms of the 100% linkage. So you don't have this clinic hopping clients. For the mayor of Lusaka, with the incentive training, I just wanted to check on the sustainability. So the payment, is it done by IPAC or the municipality does have a budget for the incentive? And then for Cameroon, just also for clarity, so this HIV user fee, are we saying in Cameroon, the healthcare services is still at a cost? Just for clarity, thank you.
Good morning, everybody. Good day. I'm Ike Kikai from the city of Johannesburg. Thank you very much for the presentations. I just want to find out from Rwanda side. You know, it's good you're focusing on the marginalized members of our society. That is the disability sector. So in this regard, I just want to find out as far as the issue, I have heard that you have actually covered most of the ground. So I just want to find out on the issue of maybe the IEC material. Is it available maybe to those marginalized, for example, the Braille or whatever? And then the issue also of the sign language in your facilities. Do you have a provision for the sign language? And then lastly on this one, I just want to check as far as the quota for the department is concerned, the employment of those sector within government departments or whatever, because it will actually assist them in one way or the other to move out of the poverty trap, and then so that they can actually face the overcome the issue of the new infection in that grouping. And then for Lagos, I just want to check, because on the data you said that 67% of the mothers access services, and then only 39% they deliver within the facilities. And then you are actually doing a good thing because the traditional birth attendants, you know, you are actually capacitating them and then also making sure that they assist in this regard, because I could see majority of them, they actually go and deliver in those. So I just wanted to check as far as the empowerment is concerned and also the issue of mortality in those respective traditional birth attendants. Thank you.
Thank you very much. Mwangani Mzumara from Ministry of Health, Malawi. My question is to Lagos. First of all, just to commend you for the great work you're doing amidst the problems that you're having. So my question is just, how are you dealing with the issues of commodities with regards to the community-based activities with the TBAs? How are you keeping track of the accountability with your commodities that they may have, whether it being testing or ART or anything like that? Thank you.
I think we have time for one last question.
And it is just one to the speaker from Lagos. Again, on the 67%, in the UK, that would be a very low take-up. So I'm from the UK, that would be a very low take-up for antenatal care. Now, you've already touched, I think, in the presentation on the reasons on that. So culture, maybe believing that childcare is a natural process, so why would you medicalise it? But is there also something, I'm not familiar with the healthcare system in Nigeria, so is there something around cost, distance, anything like that that is preventing pregnant women in general, whether HIV positive or not, from attending for antenatal care?
Sorry, I had a little bit of pressure to take one more question.
Thank you, because I raised my hand very high. Thank you. My question goes to actually Rwanda. Sorry, I forgot the name. It's been, yeah. And thank you for the expansive data that you provided regarding the topic you covered today. My sort of question goes to asking about stigma attached to three things in some of the cultures we all know. One of them, stigma about living with HIV, stigma related to some sort of disabilities, could be, you know, learning disabilities or something like that, and also stigma attached to sex and sexual activities, especially for the for those who undergo through rape in the community. What are the services are there that to help to deal with those kind of stigma?
For Rwanda. Thank you. Let me give you an extra mic. So there are two.
So thank you very much. I start by my colleague. Sorry, I didn't hear very well the name. Even the question, the first one, it's about IEC materials. So yes, our organization in partnership with the Rwanda Biomedical Center, which is a public institution working with the Ministry of Health. So we are implementing together two projects, one funded by Global Fund and another one funded by CDC, where we focus on developing, among the key activities, we are focusing on developing key IEC materials which are friendly to different categories of disabilities. So meaning, like we provide sign language on the video for the deaf people. We print the Braille document for people with visual impairment, and we do the image box for people who have mental impairment, to be able to provide to them a message related to the HIV in the way which is friendly to the communication. So the question related to the sign language in the health facilities, yes, what we do, first of all, we have to promote the sign language among deaf people, because communication, it's both sides. We have to capacitate the side of people with hearing impairment to be able to speak the sign language, because it's the only language that they can speak. Secondly, we are training healthcare providers on the basic communication which is used in the healthcare services, like to say I'm pregnant, how to test, how healthcare, something that it's very basic for the healthcare providers. Currently, we train around 1,000. It's very small. And with the partnership with our funders, we are trying to train more, but it is still a big challenge in the country. And again, in partnership with the other OPDs, we were doing what we call sign language dictionary, which is at the last stage. We are waiting the approval from the cabinet to be used. It may help for other type of communication. So the employability, the policies are okay, but we are still having a challenge because we need more to capacitate the people with disabilities to make them, to reduce the impact of HIV. So the policies are okay, but when the education, when the availability of the opportunities are not available, so it is still some challenge. Concerning the question raised by our sister, I have to talk about a double stigma. Imagine having a disability and having an HIV. It's a double stigma in the community. Even the leaders, even the healthcare providers, sometimes they are making a stigma to those people with disabilities living with HIV. So why you got that HIV, where it comes from, that kind of questions which really stigmatizing people with disabilities. But also we have to look on the self-stigma. The stigma which is caused by ourselves. I, Francois, having a physical disability, may I have like a beautiful woman like my wife? So that kind of stigma, even some people, they are saying that the people with disabilities, they are having sex by chance, not by choice. Meaning, it's like I get a chance to get someone to have sex. So the opportunities comes once. Let's do. So it's something that we have to deal with. The stigma is still there, but if I'm comparing how the situation was like 20 years ago, and the current situation, there is a progress. So we're trying to improve. Hopefully, in the next 10 years, by 2030, we will have like a zero stigma among people with disabilities. So thank you very much.
So for the city of Lagos, what was the baseline we started with? The 22% is actually the Nigerian, the country figure. So, but for us in Lagos City, that's why I said that we're increasing. So in 2020, we were about 28.2%. So when we carried out the survey, we've now moved on as of 2021 to 34.9%. So that's why I said that the Mentor Mother program has actually made a difference to us in Lagos State. Do we have mobile population? Absolutely. In Lagos, because you see it's the commercial hub, that's where everybody comes into. We have a daily influx. So they move from different LGAs, and we're one of the first cities that has disaggregated the HIV burden into municipalities. It's the first of its kind in sub-Saharan Africa. So we have a targeted intervention that we do, and we know the peculiarities of different LGAs. So I think basically that has helped us, in terms of how we need to carry out different interventions for different programs. You were talking about 39% of them deliver in TBAs. What do we do about these traditional birth attendants? How do we empower them and all of that? How do they contribute to the mortality rate? Apparently, Lagos State started since. You'd see that when I say we're doing capacity building on universal safety precautions, on HIV prevention, is not only limited to that. They work very powerfully with the Ministry of Health as well, because I coordinate the Lagos State AIDS Control Agency, which focuses on a community participation. But the Ministry of Health overlooks the entire facilities. So they also partner with the traditional birth attendants and train them in adolescent reproductive sexuality. They train them on the danger signs of pregnancy, early signs of pregnancy. So the TBAs in Lagos State are fully empowered with reproductive health. So they don't contribute to the mortality. It stays the same because they are adequately trained, and we also train them on strengthening of referral linkages. Immediately you see that this is more than what it is, please refer to the nearest facilities. So we have a handshake of that, and it's a two-way referral system. So I think that's pretty much what we do with the TBAs. Then the issue of commodities. I think pretty much the global economic recession is real. We normally front load our budget proposals to get rapid test kits, oral test kits. We started that since January. By the time we got our approvals, all the dollar rates had changed, prices had changed. So yes, we are having some issues around rapid test kits. But we coordinate the community participation, like I did say. So we give a lot of the civil society organizations, even our development partners. We meet every month. We have an advisory and implementation committee where we all identify what we're doing on the field to avoid duplication of efforts and all of that. So we render reports monthly. If you don't give us reports because it's data for action, we know that you're not doing anything. So when you come to us for support, for kits and anything, outreaches, we won't be a part of it. So I think it's that data that we render, and we make a report. We prefer solutions when we identify challenges. I think that's pretty much our accountability framework in terms of that. But we still advocate, and the governor has been really supportive. He has a very high political commitment to the HIV response, because we experienced an increased budgetary allocation from 2021 to now, about 12.2%. So we were able to accommodate a lot more stuff. But because we have about over 24.9 million people in the city of Lagos, we can't do it by ourselves. So he also inaugurated an HIV consortium where we have development partners, the government, civil society organizations. So we have a very good handshake. We do some and they do some. So we support a lot of them, you know. So we still are advocating that if we have anybody else that can help to give us some more test kits, oral self-test kits, just because of the prices that have changed globally, that would be appreciated as well. Then the issue of what's preventing the access. You know, you said I talked about the sociocultural beliefs, traditional beliefs, because the traditional birth attendants have been with us for a very long time. But I think another thing is the poor health-seeking behavior of our people. They would rather you bring the health care to them than them going to access. Well, we still have some physical barriers of geographical inaccessibility in some areas, but we're working on that to ensure that no one is left behind. So we do carry out outreaches in our hard-to-reach areas. We have a lot of riverine areas as well. We partner with, it's called the Lagos State Waterways Authority. We also have a program that we do with 5 countries. It's the Abidjan-Lagos corridor that we reach out to the fishermen as well. So we do all of this and try to bring the health system closer to our people, but we need and we continue to sensitize them on how they should take responsibility for their health care. So they should patronize the orthodox facilities that are available while empowering the traditional birth attendants that we know that they're not going to live in a long time. So that's pretty much what we're doing in Lagos. Thank you.
Thank you. Thank you very much. Hello? Yeah, thanks. For Lusaka, yes, my brother there said 16% is quite a bit high for a city like Lusaka. I think with a lot of sensitization, the number is even better. I think it would have been worse. Remember, a city that has a lot of urbanization attracts a lot of sex workers, drug abusers, alcohol abusers, and of course GBV. And during the time of the COVID, we were concentrating so much on COVID, and we forgot we had another problem.
So the numbers of HIV-related cases grew. So the last 2 years, our numbers have actually gone up. But because we neglected the sensitization on HIV and AIDS and concentrated on telling people to be careful, you know, we have COVID and so on. So we used churches, and also that's the same thing that we did even during the COVID time. We were using churches, markets to do all this campaign, and we were all partnering with civil society and also government. Government in this had a very big hand, just like they do in the public health challenges that we are facing. So on the sensitization part, even us as a local authority, we were partnering with CSOs and would go into these communities to do a lot of sensitization. But obviously during the COVID time, there was that, we relented a little bit, which I think we shouldn't. We've learned a lesson from that period. We have to continue. But we use the churches a lot, markets a lot, schools. We use schools a lot. But we also have a department in the local authority that does the education and sensitization part of it. But also, our Ministry of Health has been very supportive because public health, where HIV and AIDS is concerned, has been decentralized to the local authorities. And this means all the 116 local authorities do have a department in their local authorities where they do their campaigns and sensitization. And we are supported financially. So, and then for the other one as well, for the other question, I hope I've answered that one. Okay, and then for the other question, the trainings is sustainable for the local leadership, very sustainable. Yes, Lusaka, I should mention that Lusaka became part of the fast-track cities in 2017, 2018, of course, due to the high rate of HIV cases. But also, we're happy that we were chosen, we partnered with them. But also, the trainings that are done by IPAC and UNAIDS, they are paid for by them. They support us. But then at the same time, us as a local authority, as Lusaka City Council, we have a yearly budget that we put aside for activities on HIV and AIDS. So we've taken this very seriously as a municipality. And I think some of these trainings that we do in the communities are just wholly supported by the local authority. For example, I was talking about, I should mention the group of women, that is Lipalile group that also, the one that focuses on elimination of mother-to-child transmission. We support them as well by making sure that they have some food, that they can, feed the women that go there to volunteer, the children that go there to play. So all that is supported by the local authority. So we need to have a separate budget for all that. We can't just rely on support. But there's been a lot of support. Yeah. Thank you.
Yes. Thank you very much to our speakers. Thank you, everyone. I know that the session's taken a little bit more time than what was planned, and we did start a few minutes later, but thank you, everyone, for taking the time to sit in. Thank you to our presenters. And just to let you know that lunch is upstairs. Thank you.